Good afternoon. I'm Duke-Margolis, and I would like to personally thank you all for attending the 10th anniversary Duke Health Policy Institute Conference. My job is really easy, and that is to introduce you to someone who needs no introduction, an amazing doctor, economist, friend, and leader in health and health policy for many decades. And I'm happy to say a good friend of mine, Dr. Mark McCollum, who will take it from here. So thank you, and look forward to a really exciting afternoon.
Thank you so much for that introduction, and I'd like to add my welcome to all of you who are here with us in the room and many more who are joining us online for the Duke-Margolis 5th Health Policy Conference, which also marks the 10th anniversary of what is now the Duke-Margolis Institute at Duke University. This conference and all work reflects the vision of Bob and Lisa Margolis and Duke University to create a cross-disciplinary, university-wide enterprise that is here to advance evidence-based health policy reform, evidence into action, ideas for making a difference in healthcare reform to improve health, equity, and value of health and healthcare. That work reflects the commitment of the research staff and faculty who come from a wide range of disciplines and expertise and experiences, as well as our students from schools and programs across Duke, our diverse funders, and from our collaborations with so many of you here today. Here in person, we have together, we have about 1,000 people registered. We want to thank all of you for making our work possible over the past decade. And more importantly, we want to thank you in advance, because today is about looking forward to the next 10 years of healthcare reform. What are some of the key challenges facing health and healthcare policy? What are the key opportunities to address them, including steps we can take now to set us on a better course for the future? This is a real challenge. On the one hand, the biomedical and technological opportunities to help people identify health risks and address or prevent them have never been greater. On the other hand, healthcare costs and Americans' concerns about healthcare affordability, complexity, and other challenges have been shown, and most recently in the Gallup poll, to be top of mind, one of the highest concerns of the American public. Putting this all together, it feels like the next few years will be a crucial time for changes in health policy and healthcare to match the changes in biomedicine and technology that are possible. So, to look ahead, we have a terrific range of speakers and perspectives to address the path forward on key opportunities and challenges for health reform in America. This includes modernizing clinical trials and clinical evidence development, both to bring safe and effective treatments to the market faster and to learn more about how to use these treatments effectively for all patients and needs and care settings. It includes advancing state-led healthcare transformation, including modernizing Medicaid healthcare, where traditional models are stretched by rising costs and more person-focused approaches are emerging. It also includes enabling reforms in healthcare models to better integrate transformative treatments and cures into accessible and sustainable care models, ways to prevent health risks from progressing. It includes accelerating evidence and uptake on new strategies in healthcare transformation in employer-supported healthcare, which is very important both for healthcare costs and for reaching working Americans. Cutting through all this, we will be talking about realizing the promise of digital health and AI to promote fundamentally more affordable, accessible, and better care. In all of these areas, we realize we may not work out all of the solutions today, but we are going to talk about what is possible. I'd like to challenge all of you here to think about what kinds of policy reforms have promising support or evidence now that we could deepen and help find a pathway towards implementation to get from here to where we'd like to be in the coming years. We hope that the next few years will mark an inflection point in progress. It really feels like today that the change may need to be coming. The pressures on the one hand, the opportunities on the other. And we hope that today sparks some further ideas and collaborations for action. So two other things I want to mention in that regard. One, we are launching a Let's Connect networking program here. This Let's Connect program is designed to facilitate connection and conversation among people who are working with us and collaborating on these ideas, and to help all of you expand your networks and get to know us better too. Many attendees have already signed up, and you can tell who they are by the yellow ribbons on their badges. If you are interested in joining this program, please visit the Let's Connect hub. Near the registration tables outside of this ballroom. Also, to hear from you directly about these topics. If you have any ideas, comments, questions, or suggestions, you can use Slido, which we'll have available on screen during the conference. Of course, you know how to find us after today. And I want to thank our engagement sponsor, the John A. Hartford Foundation, for making some of these steps possible today. And I also want to thank our other important conference sponsors, which make it possible for us to have this event and such an amazing group come together. That includes Alexandria Venture Investments, Bristol Myers Squibb, Johnson & Johnson, the Peterson Center on Healthcare, and the USP. So let's get started with our first session. Congressman Jake Auchincloss, we are delighted to have you with us to kick off today. Congressman Auchincloss is here, right? And is going to come up as we're going to get started. Is representing Massachusetts. With work on the Health and Commerce Committee, and particularly its health subcommittee. His areas of focus obviously include healthcare and biomedical innovation, also clean energy, gun violence, and building a strong middle class. He has an incredible background, including degrees in economics and in finance from Harvard and from the MIT Sloan School. He served in the Marines, where he commanded infantry in Afghanistan and special operations in Panama. He's worked successfully in the private sector and has held elected public service offices at the local level and now in Congress. Thank you so much for being here with us to discuss an important new bipartisan legislative effort that you and colleagues are moving forward to modernize clinical development in the United States. I know you've got to get back up to the Hill for an E&C Health Subcommittee votes, which I think is going to touch on some of these topics as well. But just to kick us off, you're working with a bipartisan group, the Four Corners Group, which includes Republicans, Democrats, House, and Senate on this effort. And maybe, Congressman, if you could just start by telling us why this topic is such a big priority for you.
Absolutely. So first of all, thanks for having me. It's really a pleasure to be here. I've been looking forward to this conversation with you, Mark. I come at this issue of biomedical innovation both professionally and personally. I grew up in a family of medical scientists, mom, dad, stepfather, and aunts and uncles, and it's personal. I was taught to respect science and the wonders of biomedical R&D from an early age. And I represent a district, the suburbs of Boston, where we start biotech companies on the sidelines of soccer games, and where the physician scientists and the academic researchers and the clinicians really are driving healthcare innovation. So I come to this representing a district that I think believes in it professionally, and I'm on the committee of jurisdiction over it. Why now? Why this issue? I think it's a confluence of three things. The first, as many of you will have heard, is what's been called Eroom's law, right? The opposite of Moore's law, and the affliction of biomedical R&D, and particularly the clinical trials process, where in fact productivity, unlike with semiconductors, has actually gotten worse over the last 50 years. And this has bedeviled a lot of people and economists, and there's a lot of debate about why exactly productivity seems to be going down for R&D. But I think everybody agrees that at least one element of that is that clinical trials take too long, and they're inefficient, and they cost too much. And remediating that would be a major way to widen one bottleneck and perhaps increase the productivity of biomedical R&D. So I think there's that sort of economic imperative. There's a strategic imperative. China has gone in the last 5 years from 0 to probably like 50% of all licensed drugs. They are on the biotech warpath, and we've got to run faster. Some people say we also got to play keep away from China. We can debate that, but definitely we got to run faster here in the United States. And then the third thing is politically, there's so much that we disagree about in Washington. I've been a ferocious critic of Marty McCary, and obviously he's gone now. I've been a ferocious critic of RFK Jr. and his anti-vax rhetoric. Like, there's so much that we disagree about. I don't agree with the most favored nation pricing approach that this administration has taken with Globe and Guard. And so if you try to get stuff done in this incredibly partisan environment where there's so many fundamental disputes about healthcare, better, faster, cheaper clinical trials is a good common ground. I mean, that is a quadruple win across the board: patients, industry, economic competitiveness, and our healthcare infrastructure itself.
Yeah. Now, you're working on this with a bipartisan group, so it's Representative Morgan Griffith, who is the subcommittee head now,
Yep.
and I know getting ready for that, probably working with the Rules Committee, right?
Yes,
right
yes.
as we speak. Senator Mike Rounds of South Dakota, Senator John Hickenlooper of Colorado. So obviously, there's a shared belief there. I don't think they are in the same position you are with some of the issues you just described: FDA leadership, HHS leadership, et cetera. This is not a year when people are expecting much to happen in terms of bipartisan legislation. I mean, that's obvious. So why now? Why are you all, you have lots of things to do. Why this effort? And we'll talk a little bit more about what's going into it in a minute, but it's some serious work on the part of all of you. Why now?
PDUFA is next year. So the letter of intent may be in January of 27. I want this bill to pass with PDUFA. That's my goal, which means that we got to start now. We got to start with a discussion draft. We want to get input from people like you all in this room. We want to then release final legislative text, mark it up, demonstrate committee support this year, and that way, when we're negotiating PDUFA next year, it can catch a ride. One thing I've learned, been here for 6 years now, is you got to pack your bags before the train comes.
And I hope that is a train that should be coming in 2027. You mentioned some of the challenges at FDA now, and I want to keep the focus on the legislation, but it seems like this kind of bipartisan process is also a way to give some recognition and maybe cover for further action by FDA. I mean, and as I understand the details in the framework that you're putting together, I think I should say, for those of you who are here, there's a copy of that discussion draft, and I know your staff is interested in getting more input on that, as you mentioned. It seems it does include a number of elements that are really building on current initiatives to make progress at FDA. So conducting first-in-human trials faster, that's been a focus area. I'll just read off a few more that this group, a lot of our audience is very committed to advancing this work. Things like making it easier to participate in so-called platform trials, which increasingly involve digital supports, AI tools, things to make it easier to integrate them into regular practice, to get reliable data directly from trial participants. FDA reforms to enable simpler but reliable measurement of clinical endpoints that matter to patients, leveraging some of the extensive work going on now in agencies, including CMS and the Office of the National Coordinator for Health IT, for improving data sharing to get to better quality of care. So there are a lot of pieces there, but it seems like what this effort is really doing is trying to put those together around near-term opportunities to make a difference.
Yes, near and I would say medium to long term. And I would hazard that there probably aren't brand new ideas in this document. I think that there are a lot of really good ideas that a lot of smart people have been talking about for a number of years that are really don't really have a partisan valence to them. And what we are trying to do here is wrestle this into one synthesized piece of legislation that can get four corners support, and that takes it from a point of care clinical trial infrastructure in this country. So it's not one-off academic medical centers and IRBs, but trying to actually have more bandwidth where as people are getting care, they're also getting the opportunity to enroll in clinical trials. We're trying to do some of the early feedback and modernization efforts at the FDA so that innovators have early conversations with their regulators to understand what are the endpoints and have confidence in the consistency of those endpoints across review teams and across time. And then, as you said, sort of, again, not new ideas, but adopting some of the proposed innovations around platform trials and Bayesian statistics and that kind of stuff. And we're trying to put it into one digestible format that allows us over the next 2 to 10 years to scale up this clinical trial infrastructure. And just for the goal for me is for a given dollar of R&D spend, get more shots on goal, because you can get more medicines into a phase 3 for any given dollar spent. There's a lot of discussion these days, obviously, about computational drug discovery and AI and how many more targets and how many more molecules can be conceived upon with AI. I don't doubt it, but the bottleneck remains, right? Like, it's the world of bits can get fast, but the world of atoms is going to be stubborn, and we got to make the world of atoms, we got to widen that aperture to respond to the world of bits.
Yeah, I really like that analogy. One of the things that we've been doing at Duke-Margolis, as you know, we've really enjoyed collaborating with the staffs involved in this effort, is a number of working on a number of evidence-based approaches to accelerate clinical development. And in the course of that, we've pulled together a lot of our findings into a preliminary draft report that we have put up on our website today around advancing this idea. I think as you're talking about putting in your legislation, cures in care, getting these treatments into larger scale clinical testing and doing it more efficiently. Was it bits and bytes with the atoms into these transformative efforts. In the course of doing that, we've already heard from a number of organizations and collaborations that are involved in trying to advance the kinds of activities that you're talking about. And I'll give you one example. This is a leading question. Our next panel includes Professor Jennifer Doudna, who's been obviously a leader in the work on CRISPR gene editing and now on developing evidence on getting this technology safely and effectively into a broader range of applications. They've done in collaboration with other academic groups and collaborators, including the University of Pennsylvania, the development of a potential umbrella trial platform. But one of the things that we've heard from the participants in that effort is that for this really to work, there needs to be a way to do easy, long-term follow-up of the participants around monitoring for safety issues, around long-term effectiveness. These are, intended to be one and done cures that can potentially scale up really broadly. Is this the kind of example that you have in mind? And one of the things that we're asking for as part of this effort is for people to send in and talk with us about ways to highlight other examples like that, or make this help to make this a reality sooner.
Absolutely. It's what part of what we're envisioning. And as you said, the FDA has started to already look at this, plausible mechanism, et cetera. I would say that we also have to recognize with the gene therapies that, yes, an improved clinical trial is going to be critical, but we also need payment mechanisms that make this make sense. Because right now the science is outpacing the economics for gene therapies. And I really am concerned that we're going to leave a lot of things on the shelf if we don't have a way for insurance companies to be able to measure outcomes and then to be able to pay for the value of outcomes. And that's just a different model than a model that was really built on this idea of, you take a pill a day for 20 years and that's how we pay for things. This is very different now. And I want to see the insurance industry move a lot faster and more creatively on how they do, whether it's insurance-linked liabilities, models to evaluate outcomes. Like, I'm a little tired of hearing them claim that they can't figure out how to pay for this. They need to get there, because otherwise what we're going to start seeing is you're going to start seeing particularly I think in the employer markets, you're going to start seeing insurance contracts that carve out gene therapies and genetic conditions.
Just the contracts don't even come together because it seems like too many pieces, too hard to do.
Well, it's just going to be an exemption from and an employee won't know that, right? You're getting a new job. You don't know that the kid that you haven't even had yet might have a genetic disorder. And so you don't understand that the insurance that you're getting from your employer doesn't cover it. And then you have a kid, they have a genetic disorder, and your employer says they won't pay for it. That to me is fundamentally unacceptable outcome. And so we have to have both the payment model as well as the clinical trial model for these therapies, because they're mind-blowing science.
I think you just teed up a great challenge for a couple of our upcoming panels this afternoon. Thanks for that. And it's great to hear that as you're working on this legislation to create more of an infrastructure, it should make it easier for getting this kind of evidence and supporting these kinds of content.
Well, because they're kind of the same problem, right? If you're trying to see safety and efficacy in a phase 3, right, that's sort of the same kind of questions that payers are going to be having. And I think they can even overlap. There's been some of that with real world trials, right? So I think that they're very much in sync.
Yeah. One of the other big drivers for interest in improving U.S. biomedical innovation efficiency, especially in the clinical development process where most of the costs and time goes, and you alluded to this earlier, is global competitiveness. I know you've been thinking about that a lot too, and your colleagues in Congress. That does seem like a bipartisan issue that will get action soon. And I just appreciate your saying a little bit more about how this kind of effort fits into that pressure.
Particularly with China, you're talking about. Yeah. I think so. As I implied earlier, this is a no regret investment that we can make. Better, faster, cheaper clinical trials, it just helps across the board for U.S. economic competitiveness. It does not fully address what is another debate about, okay, yes, we want to run faster as America on clinical trials. Do we also want to play keep away from China? And so I served on the select committee on China last Congress. I served on the health subcommittee this Congress. So I've seen many of the perspectives on this. I'll try to I'll give both of the strongest arguments. The strongest argument in the camp of the China hawks who say play keep away from China is basically what they say is China's running the same playbook right now that they were running on batteries, that they were running on microelectronics, that they were running on solar panels, that they were running on fission in the last 25 years, which is to say it's a 3-part playbook. Number 1, joint ventures with the West to extract knowledge and know-how. Part 2, massive state subsidy to scale up your domestic capacity, 1,000 flowers bloom. Phase 3, ferociously winnowing down to a few national champions, and then globalize it and undercut on price the rest of the world. And folks are saying they are doing it to biotech the same exact way that they did it to batteries before. So that's argument in the China hawk camp. The argument in the no, we should be engaging with them camp is this is a high fixed cost industry with low marginal costs, which means you want to spread those fixed costs globally, and then you want to sell into as big of an addressable market as possible because that lowers prices for everybody. And I think there's merits, frankly, in both of those camps. I think that good diplomacy could get you best of both worlds. And what I mean by that is, I don't think this president's going to do it this week in China, but if we could establish biology as a defense-only domain it would unlock the ability for us to cooperate and compete in a productive way as opposed to a destructive way. There's 5 domains right now: air, sea, land, space, and cyberspace. And those 5 domains are all offense and defense. It's acceptable in all 5 of those domains internationally to do both hit your opponent and to play defense. Biology is the 6th domain, and it has to be defense only. We need to have strong international compact that there's no acceptable offensive use in biology, period. The problem is we don't trust China that they're doing that. They don't trust us that we're doing that. We've got to establish that baseline. Then you could start to talk about harmonizing clinical trial standards, because I do think it's true that there's not informed consent at a lot of these PLA-run hospitals where these clinical trials are being run. And then, and this is the real unlock, then you get the Chinese to pay more for new medicines, because they radically underpay. They're free riding on our R&D right now. And if we could start with that basis of trust, we could get them to pay more for new medicines and spread the cost of R&D across a much larger population and speed more cures to market.
And the kinds of steps that you're describing in the legislation could potentially establish more of a global standard.
100%. There's a whole global harmony.
Bring these potential cures forward more effectively.
That's right. What I really worry about is if we just pull out of China, if we just say no way, no how, no clinical trials data whatsoever, I think that actually has a lot of unintended consequences. I think you start to see some pharma companies start to like kind of Euro wash their drugs and go through Europe instead. And I think you start to see that China actually takes the lead on R&D, and you actually start to see that they become the dominant innovation driver, and that Europe is actually starting to orient towards them for new medicine. Like I think we got to be very careful by thinking that we can just pull out and expect that we can hide behind our 2 oceans and still lead the world on biomedical R&D. I just don't think that's true.
Well, I really appreciate your vision, your thoughtful vision for U.S. global leadership in such an important area, not only for the health of Americans, but for U.S. productivity, U.S. biomedical, economic growth, and health of people globally. This is going to be this seems like a big set of issues. So you mentioned that you're looking for input. What do you see as the next steps happening from here to get you to legislation alongside PDUFA next year?
Most of you, I hope, have a printed copy of the legislative summary for what we've done.
Or get it.
We're happy to share legislative text with anybody who wants to see the actual legislative text. We would be asking for feedback. I think we're asking for feedback by July 1st from any interested stakeholders. We want to hear from everybody. And then we want to turn that around into finalized text that we want to be able to get a hearing on and mark up this fall. And then, like I said, having a bill that has been vetted already through committee makes it much easier to then put it on to PDUFA as a policy rider.
And during this process, Duke-Margolis intends to continue to support the evidence for policy into action.
Not only has Duke-Margolis been a fantastic thought partner, I also want to give a shout out to Paul Kim, who some of you may know Paul Kim, some of you may not, but Paul Kim has been a tremendous thought partner and assistance with ledge drafting. So thanks, Paul, if you're watching.
I think he is, if he's not exhausted today. But so in terms of next steps, following up with your staff and paying attention to the process that you're going to be moving forward in Congress. From the Duke-Margolis standpoint, we have information up about the evidence and policy directions related to this initiative in that report, and in obviously a lot of our related biomedical innovation work streams. And there will be further developments on that too. We all want to hear from you. This is a very challenging time. You started off by mentioning some of the disruptions at FDA, all of the other political issues. This conference is about looking ahead, and you've given, I think, everybody here some reason for optimism, as well as some challenges in getting there in a really important area of healthcare reform around biomedical innovation, clinical development. Any advice further for people here with us today who all share your hope for much better, more accessible, and innovative healthcare in the years ahead?
I don't think I'm in a position to offer advice. Everyone in this room is very, very smart on healthcare. I would offer a challenge to everybody to rally around one that I'm personally passionate about, which is I think this country should cure Alzheimer's disease by 2040. We have 15 million Americans are going to have Alzheimer's by 2050. Each requires 3 caregivers. That's 60 million Americans suffering from really untold emotional, moral, medical, and indeed financial burden. And let's be real, we don't really have great answers on this disease right now. And there's a tremendous amount of energy right now about going to Mars. I think going to Mars is cool. If Musk and Bezos want to pay for it, fine. But we actually know a lot more about Mars than we know about the human brain. And I think a scientific enterprise focused on understanding the human brain well enough that we can cure Alzheimer's, well enough that we can cure schizophrenia, which is also a tremendous moral and emotional burden in this country. I think that just does a tremendous amount for the American public. And it also gives people a reason to think the government can do hard stuff again. People don't think government's all that good at its job right now, and we got to give people a reason to believe again.
Seems like a great opportunity for public-private innovation.
Totally.
Something
and
really
clinical
matters.
trials reform will help with that, obviously, as well.
Yeah. All right. I know you have to get back up to the Hill for that E&C subcommittee hearing and all the votes. Thank you for taking time out of a very busy day to be here, and thank you for your leadership. I'd like to introduce for this discussion about the modest topic of the potential for healthcare and health in the next decade and the steps needed to fulfill that potential. I'd like to welcome our panelist, Professor Jennifer Doudna, as the 2020 Nobel Prize recipient, and professor of biochemistry, biophysics, and structural biology at the University of California, Berkeley. Also leads the Innovative Genomics Institute there as well. Karen DeSalvo is retired fairly recently, Chief Health Officer at Google, and prior to that has a tremendous amount of experience. I first got to know you working in local population health and public health, and then leading health information technology and interoperability development for the federal government, among other things. And joining us online from California is Professor Bob Wachter, who is professor and chair of the Department of Medicine at the University of California, San Francisco. He's authored, for those of you who know him well, really engaging writer and thinker over the years about how new technologies and innovations are interacting with healthcare and potentially transforming it, including a very popular new book, A Giant Leap, How AI is Transforming Healthcare and What That Means for Our Future. So, boy, this sounds like a great panel for the topics today. And just to get started, we've already discussed this. Representative Auchincloss couldn't have been more articulate about the unprecedented opportunities for biomedical innovation and potentially technology and AI to improve care, to address unmet medical needs, medical factors, non-medical factors, putting them together to make healthcare more personalized, more affordable, more accessible, more prevention-oriented. But despite those opportunities, we are not seeing that yet today. Lots of activities going on. And again, it seems like the next few years, the next decades are going to be really, next decade will be really critical. So Jennifer, I'd like to start with you. One of these fundamental challenges is around more effective drugs, and especially as Representative Auchincloss talked about, one and done personalized therapies that hold the promise of cures. These include not only a growing range of cures for single gene disorders, now treatable using CRISPR and related technologies, but maybe expansions of that as well. So maybe starting out with the optimistic side, from a biomedical standpoint, what's possible in the next decade?
Well, Mark, it's a great pleasure to be here. Hello, everybody. So I've been involved for the last almost 15 years now in work that is focused on one and done therapies using gene editing called CRISPR. And what's exciting today is that we can already see evidence that this is coming to the fore in terms of being able to treat rare diseases in particular. That wonderful example you referenced in the previous session of a baby treated for a rare disease out of the Children's Hospital of Philadelphia, very, very exciting, as well as the FDA approved.
Well, first of all, congratulations on 10 years. and I look forward to celebrating your impact over the next 10. It's nice to see a lot of familiar faces. And when Mark wrangled me into coming to DC to do this, he asked me to think about unfinished business and how that might accelerate or help this kind of work that Jennifer's describing, or all the ways that we want to improve the population's health. And it brought me back actually to 36 years ago, when I was a third-year medical student and doing my psychiatry rotation. And I was in a clinic with a preceptor, Dr. Gallant, who was a psychiatrist. The clinic was for uninsured individuals. In this case, it was a person who was recently incarcerated who had substance use disorder and was in recovery. And my preceptor finished his note because it was 1990, and so it was handwritten. Then he looked up and looked at the patient and said, "I'm going to read you what I've written." And he read the note to this gentleman, and the gentleman's posture changed. He sat up straighter. He was making better eye contact. He was activated just by the sheer transfer of that knowledge, which was also a transfer of power. It was extremely formative for me as a young physician, and it's been very formative in the way I've thought about ways that I can help improve population health, one person at a time, or as we like to say in Silicon Valley, at scale. And that idea that transferring knowledge, really at the foundation of that knowledge is data. And it is only useful if it's at the right place at the right time to take the right action. And in the case of inventing incredible therapeutic interventions, that's wonderful. It doesn't help anybody if they're not able to access it. And it doesn't certainly help people in a way that drives equity if it's not available to everyone. And so this idea of unfinished business and thinking about how far we actually have come in the last 36 years as a country is we have realized this world in which everyone has access to their health information. They have too much access to too many sources of health information. So there's active work afoot to create a more unified personal health record view. And it's also true.
When you say too many, so fragmented data, inconsistent.
I mean, the kitschy term is we call it hyperportalosis, which means you've got all these places that you're looking for information and there's no back end that pulls it all together for you. Now, there are ways that that's starting to come together, and we can talk about the private sector efforts. There's also a real push by HHS to see that this is going to manifest in a way that has the right identity and the right privacy and the right security, and is done in a way that is amenable to individuals. So that's one piece of the puzzle, to activate the population to improve, get there earlier before they need interventions, to help them know about and manage their own health, not just their own health care. The second piece of this is how far we've come in the operability layer, just even in the last decade. If you think about how clunky the systems were years ago, we were just celebrating the fact that we had, I'm going to use a strong verb here, apologies, shoved electronic health records into practices around the country. The nurses got the worst of it first. I always like to apologize to the nurses. They never complained. Then the physicians got it. They were more vocal complaints. But the reality of that is it created this foundational layer that is now allowing us to take advantage of newer technologies like AI and to collect real world evidence to see the impact of therapeutics. All this is possible now because we invested that as a country years ago. What we didn't do well, I think, was think about how it was going to be harmonized. We thought about it more as that data was power, that power will belong either to the health system, maybe the payer increasingly, but most certainly, I think, to the electronic health record companies. And so the data is living in these little pockets, and only now are we beginning to, yes, we have interoperability. You can measure it and say the vast majority of hospitals, some 90+%, say that they can exchange and share and incorporate data, but it's not the reality we experience in everyday life. And the reasons for that are honestly somewhat technical, but that's not really the issue. It's the lack of adoption of some of the technical infrastructure, like moving to the cloud, like adopting FHIR standards, which is a open source standard that has been being pushed since I was national coordinator 10 years ago. But still, the industry is kind of dragging its feet. But also, I think Gen AI is a way that we're going to be able to accelerate interoperability especially if we can overcome this hoarding of the knowledge and power by the health systems that have the data, not just to the consumer, to the population that we're here to serve, but to each other, and to the scientists. It is genuinely, I think, it's a good time to be considering the potential and possibility of all these use cases of data, because we have laid a strong foundation, and I think we're continuing to do it. I'd say we need to move a lot faster, or we're going to miss a really important window of being able to take advantage of those data and insights to create not only better population health, but also to create a system that meets the expectations of the population, which it's just not right now, whether it's getting the right therapeutic earlier or faster or more affordably, or having a health system that's accessible and sort of culturally appropriate and meets your needs in a high quality way. We are still working in the health system on data that's at least 2 years old. Yeah. And the general population finds that very unacceptable, which we'll talk about a little bit, but I think it's one of the reasons that, given the opportunity, they're I'll say flocking to using what's emerging as an alternative healthcare system, especially primary care. They want primary care in their pocket. They want it to be through the chatbot they already use to plan their kid's birthday party. That they seem very like Gemini, ChatGPT, Claude, a whole host of systems that have said, give us your health data, we'll host it for you, we'll keep it private and secure, and we'll use that to help you navigate your health journey and your healthcare journey. And it's just, I think will it replace traditional healthcare? I don't think it can entirely, but I think it's a really important opportunity for consumers and for population health if it's done right. We can talk more about ways that you could structure that, but it's also, I think, a call to action for the healthcare system that we're moving too slowly to meet the needs and expectations of the population to have this kind of optimally always on improving health system that's driven by data and not just by the guesses that we might have in the system.
That was a really awesome answer, because you combine that vision with, you actually use the term bulk fire, I think. So
I don't know if I said bulk fire, but I meant to. Yes.
A new hyperportalosis. I haven't heard that one before. I was having a discussion yesterday with some people who work very closely with primary care providers who are trying to advance primary care. I think their technical term was all bollocksed up in terms of getting access to this critical data. So this is exactly as I planned at the time to transition to Bob. Bob, I hope you can hear me and that we've got the tech worked out for this session. We were just talking about the potential for AI. I think there's views out there that, while it hasn't happened yet, it's going to be a solution to all these problems. I think your view so far has been more measured, but I really appreciate your comments at this point. And I know you probably didn't get to hear everything that's been said so far in the panel, but appreciate your being with us. AI does already seem transformative in some ways, at least some of the usual processes that have been such headaches in our healthcare system, documentation, notes, coding, billing, perhaps. Where are we in terms of further transformation, really getting to the kinds of healthcare delivery that Jennifer and Karen have been talking about?
Well, first of all, thanks for having me. It's an honor to be with this group, and sorry I couldn't be there. Yeah, I heard most of what Karen said and a little bit of what Jennifer said in the beginning, but let me start by saying I did land, after 2 years of research and interviewing about 110 people for my book, in a place of a decent amount of optimism, which is shocking because I wrote a book 10 years ago about the electronic health record, which is an incredibly grumpy book about how things went off the rails and we did not get that right. But I'm with Karen. I think that actually high tech and meaningful use, as painful as they were absolutely foundational. We needed to lay the tracks. We needed to have the data in digital form. That was not happening naturally. Whether it was, we called them incentives or bribes or whatever it was, the healthcare system needed to be pushed to go digital. And our mistake was thinking that was the answer, as opposed to that was the foundation. And it really was the foundation, but we were waiting then for a tool that could help take all of this data, much of which is in unstructured form. If you think about, so much of medicine is in the form of doctor-patient or clinician-patient conversations, or notes that various people write. So we needed a tool that could take that data and use it in ways that meaningfully improve health and healthcare. I landed in writing this book in a place of a decent amount of optimism, hopefully not sort of taken too much by the hype. And I did that mainly because this is the way I like to frame it. On November 29th, 2022, which is the day before the public release of ChatGPT, I wasn't thinking that I needed a better search engine. In fact, I'm not all that imaginative. I couldn't imagine a better search engine than Google. Like, that's what search is. You put it into Google and you get a bunch of links, and that's terrific. And yet the day ChatGPT came out, and then ultimately Gemini and Claude, it was like, this is better. This is a better way. There's a better way of doing this thing called search. But on November 29th, 2022, I don't know anyone who's not psychotic who said, I can't imagine a better healthcare system. No doctor, nurse, administrator, regulator, or patient or family member said that. And so it was obvious that when GPT and generative AI became a thing, that it was almost perfectly built to solve many of the problems and take advantage of the tracks that people like Karen and others helped us lay over the decade previously. The kinds of problems, talking about information overload, it's not only that the information lives in 100 different places, it's that the amount of information that I need to capture as a doctor talking to a patient is such that I will not make eye contact with the patient. I will be looking down, checking boxes, unless I have an AI scribe. And now at UCSF and most big places now, every clinician has access to an AI scribe, a tool that didn't exist 4 years ago and has now become almost ho-hum commodity. It's remarkable. 1 out of 5 patients has a medical record longer than Moby Dick. You may have forgotten Moby Dick from junior high, but that's 600 pages. The idea that I can review that in the 3 minutes that I have before seeing a patient is a joke. Can't possibly be done. We now have access to a tool that you press a button and 60 seconds later, it summarizes the patient's medical record. And there are several thousand medical articles published every day. I will confess to you that I can't read all of them, and yet AI, of course, can summarize them. And you were talking, Mark, about the things that have already happened, like back office, billing, scribes, chart summarization. To me, those are singles. The real win here, the real home run, is clinical decision support and the astounding uptake of open evidence, which is sort of the most sort of tailored GPT or generative AI tailored for the needs of clinicians, is unbelievable. Essentially, every doctor now over the course of a couple of years is using that tool to help them with diagnosis, to help them make decisions about treatments. And I think it shows the way toward a future where clinicians will be getting much more help, which is what they're going to need to figure out diagnosis, to figure out the best and most appropriate and most evidence-based, and I'm hoping most cost-effective therapies. I'll say one more thing, which is one of the real challenges here is trying to figure out when is good enough good enough. And by that, I mean the AI tool summarizing that 700-page record is not perfect, but it's better than me, given the amount of time I have to do that. The AI scribe is not perfect, but it allows me to make eye contact with a patient, which is good for docs and good for patients. The open evidence, or using Gemini or GPT for the purpose of suggesting diagnoses, is not perfect, but it's probably better than many of us, and I think better than me. I use it all the time as a curbside consultant to help make me smarter than I would be otherwise about a given patient problem. The problem there, of course, is that we will tend to hold technology to a higher standard than we hold humans. And the model case here, of course, is Waymo, which is demonstrably safer than a car with a driver. Over 100 million miles without a human fatality yet. It's unbelievable. I take a Waymo about once a week, sometimes take a nap in the back seat, and completely trust that it will get me to my destination. And then 4 or 5 months ago, Waymo ran over a cat in San Francisco, and it became an international headline. We don't talk about how many Uber drivers have driven over cats, or how many of us have driven over animals on the road. So it's going to be tricky, and that's going to be a regulatory problem that comes up where we say, do we hold it to a standard of perfection, or do we hold it to a standard of better than the status quo, which, believe me, is not perfection? I think that's a tricky call, and I think we have to push ourselves to not hold it to an unreasonably high standard and not let the incumbents, and that includes physicians, push us to hold it to a standard that's impossible, in part to hold on to their franchise. And I think the politics and the regulations there may play out partly around the lines of what is the standard that we hold these tools to. And I hope the standard is something like, is it substantially better than the status quo for patients in terms of cost, convenience, accuracy. And I think that's unfortunately in healthcare a relatively low bar.
Yeah, well, I got to say, you covered a lot there. I have to say, I've known Bob for a long time. This is the most optimistic I've ever heard him sound. So
Got
that's
that right.
something but that goes to the importance of the next few years. Bob, you may have missed Jennifer's comments, but I think I could briefly summarize by saying, well, this is all going to be great if we can work out the regulatory and the payment. So policy can make a difference. And we have the whole rest of the afternoon for we're going to really be pushing the rest of our panels on the policy issues. I want to encourage you to talk a little bit more about that, but it seems like there's some different visions here, and not to oversimplify what is going to be a very dynamic and hopefully productive decade of progress along the lines you're describing. Bob, you talked about health systems getting more effective at delivering better outcomes at a lower cost, not by hitting signals, but by using open evidence and whatever tools follow from that available within these systems, which are, you're right, they're adopting scribes, they're also adopting their own versions of Claude or ChatGPT, building off all of the data that they have, where they've made some progress on the interoperability issues, at least within their system. So that's sort of like a big systems-based approach to solving these problems. Karen, you talked briefly, at least, about a different one, which has gotten more of a head start, I think, in terms of like number of people, number of patients engaged, ease of access, low cost, due respect to UCSF pricing, which is the more direct to people digital AI tools and the data that's going in there. As you pointed out, that's not the same data that's available at UCSF and other places because of the hyperport. I'm just going to say bollock stuff. Bollock up data. There's a third, which is healthcare organizations that are maybe more specialized. Some of the advanced primary care groups that are in accountable care organizations, alternate payment models, maybe a bit more specialty care groups that are trying to deliver, behavioral health services or other types of care that have their own challenges of data limitations, but are trying to move in these payment, other reform directions. One could imagine, Jennifer, with your approach, maybe a sort of a specialized set of providers, maybe not every single major academic system, maybe a different approach, a care that's based not in the unit of office visits and encounters, but care that's based on care management, remote monitoring, and a team-based integration around it. Those seem like kind of different futures, all of which are happening to some extent now. I'd like each of you to comment a little bit about where are we going from here, and what are the big worries or opportunities that you see that policy should try to address to steer us in the right direction?
Let me start, since I'll maybe talk about the base layer for the use cases, because the reality, I think, is that these are just use cases for a set of data that can be accessed in a variety of ways and stored in a variety of ways. So it's possible to conceive of a future in which there is a set of consumer-owned data where I have a personal health record that is in a FHIR server, that is my individual server, maybe hosted by a trusted intermediary that's been anointed by some entity, could be the Karen Alliance, could be the government, could be both. That is Karen's data. And it doesn't have to just be my electronic health record data. It can be wearables, it can be other sensor data, it can be environmental data that I might want to share about my travel and exposures, et cetera, so that it's a bigger picture of a more robust picture of my health. Laboratory, there's a list that you could think about that would be in my personal server. That all together, if I chose to share that as a consumer into my state health department or into a research environment, could inform other use cases.
Our state panel is going to follow. It also includes things like nutrition needs, housing needs.
So that's the sort of the Karen instance, and you couple that across 320 million people, and you have a population health database that some subset of those things with permission is shared into or can be accessed in a federated model. It doesn't have to be in a master patient index. It can also, on the other side, it's going to be, I think, deeper, richer data that healthcare systems will have. Like, for example, as an individual, I need to know I had a flu shot, but I don't need to know the lot number and all the other details, right? But the healthcare system needs to track that because there might be a recall or some other issue. So there's a overlapping but different set of data that the health systems are going to want to have, and so and payers very similarly. But there's other data sources. There's laboratory, there's public health case reporting, other sources of data that not just the EHR. It's just the key thing that I want to keep saying here is that I think 10 years ago, we thought of the electronic health record as telling the story of someone's health. And if you learn or remember nothing else today, please try to remember that the data picture of someone's health is much broader than just the electronic health record. That's what happens when they enter the healthcare system. But the rest of our lives, we are living, breathing, working, sleeping, all the things that actually really affect our health to get us to the point where we go into the system. So that kind of parallel system can easily be tapped and exchanged through a set of endpoints or APIs that are harmonized, safe, and all those things. And you could do that through a structure. We have one now called TEFCA that has been created by the government. They're not leaning in on it a lot, so it's kind of a little weak little sister of interoperability. But if they decided they wanted to lean in more, there would be a way for all that data to exchange, and there would be a way for those sets of data to be made useful for the use cases you're hearing about. It's maybe one easy way for people to think about it is your bank account. That's data that's useful to the bank and for other purposes, like for understanding the economy. People can't grow in and grab your data, and you can't change the number in your bank account, but you have access to that, and you can add to it, you can take out of it with certain permission. So it's a similar kind of idea that it's a trusted source of data, but I think that's where we need to go, Mark, because then you have these two data layers, one that's gives you more on prevention and sort of all the other influences on health, and one that tells you more how the health system's performing, and depending upon where the scientists or the healthcare providers or the tech companies are in that journey, they're going to want to access and inform that data. But consumers are going to be helped by it all across the journey.
Bob, with your newfound optimism, what does UCSF look like in 10 years, meeting the potential high-end expectations, better outcomes, lower costs, fitting in with the kind of more comprehensive support for health, and I would include from what you're saying, Karen, wellness, more emphasis on prevention, ways of integrating these curative or at least effective early interventions to slow or reverse health declines. What does UCSF look like, and any key points on getting there?
Yeah, there's a lot there to chew on. I really appreciate Karen's thoughts. I think one of the questions is, are these sort of two parallel health systems, one sort of the consumer-facing health system with data coming off your watch and your ring and a camera in your house and et cetera, and your clothes, and another that is sort of a version of the legacy healthcare system that I hope, will modernize quickly, or do they sort of morph into one thing? And does the electronic health record become the scaffolding on which all of it sort of comes together in one place? I think that's unknown. I think that some of that will depend on policy choices. Some of that depends on the payment system. So a payment system that continues to incentivize the healthcare system to do stuff probably spends a little bit less energy on all of the prevention and wellness part of this than a health system that is incentivized to keep people healthy. And so, value-based care has been around the corner for 25 years. If it fully comes around the corner and becomes real, then I think you get more integration of the kind of wellness, keep people healthy out of the hospital, and we'll spend the money to create that system than you will get if it's all fee for service. What does it look like? It feels like the end game's pretty clear, that all of the data, and I don't know when we get there, but all of the data are fed into a sort of single point of truth, that there's a huge amount of analysis that's going on by AI, because you want to drive a doctor crazy, say, oh, all that data, your patients are wearing watches and rings, et cetera, and that's going to all come, and their glucose and whatever, and their, serum rhubarb, it's all going to come to you, and you're going to have all that data to help manage your patients. And they will say, I will quit this afternoon. I can't possibly manage that. And I'm also worried about getting sued if there's something that I miss. So the only way that works is there some new system of air traffic control that's mostly AI enabled, that sort of keeps tabs on patients, but also connects back to the healthcare system. Because I really still believe that there will be patients that now are not doing well and need to see a doctor or need to go to the hospital or need surgery or are going to have a baby, et cetera, et cetera. So I think all of this has to be interconnected. I would say, Mark, on cost, as you've seen, some of the early data is showing that some of the AI that we have is raising costs because every entity is going to use it to their economic advantage and look for an ROI. And so right now, sort of the biggest cost signal seems to be that everybody's billing more effectively, which is sort of not where we want to go. The mechanisms by which this can lower costs, and I think it will, is sort of administrative costs and all the people in the billing department and the care coordination department, and et cetera. Can those people sadly be replaced, or at least we need fewer of them with AI, and maybe also some of the clinical workforce? I think that will take far longer. But the main impact on cost, I think, is in clinical decision support, which is, does the system drive us to the most cost-effective options? And that's a judgment call. I think people sometimes have the kind of mistaken belief that once we fully have our AI act together, AI will tell me that the right medicine for my patient with asthma or cancer is medication X, or for Alzheimer's, hearkening back to your last conversation. There's no right answer as to whether it's medication X. It may be a medication that Jennifer's come up with that is spectacularly effective, but costs $500,000 but gives the patient, extra years of life and all that. There's some inherently values-based decision that has to underlie what does the electronic health record, digital decision support tell you is the right thing to do, because these recommendations are going to get better and more prescriptive, but unless they tell us the most cost-effective option, they may actually raise costs if they are agnostic on cost and just deliver the recommendation that delivers the best outcome. So a lot of tricky decisions underlie these kinds of clinical decision support systems.
Yeah, and it does seem like there's a lot of interesting views about where things could end up. It does seem like there's common agreement that we should be aiming for a single source of truth data that each person is able to bring together. I think, Karen, you're saying that maybe more on the personal side, or maybe, I know we've got a lot of people here working in primary care organizations are trying to become more advanced and be sort of really good at putting those risks together and connecting people to the non-medical or the specialized services that may matter. To Bob's point about costs and really doing it right, Jennifer, maybe we come back to you. As you look ahead to the technology, do you see healthcare systems, meaning the UCSF types, academic centers, doing all of this, or could it be more sort of a primary care, either individual bot driven or advanced primary care practice driven, connecting you to organizations or entities that are really good at better outcomes, lower costs for these different kinds of health risks and problems that arise?
Well, a couple of thoughts based on what Bob and Karen just said. I think one is that the banking system after the 2008 financial crisis figured out how to aggregate financial data in an anonymized fashion that allow big banks to access each other's data for modeling, et cetera. I feel like we ought to be able to do that in our healthcare system, right? It would be amazing to have that kind of aggregated, anonymized data that would allow increasingly accurate predictions about healthcare outcomes given a particular path of treatment. And then to what you said, Bob, about also factoring in the economics of that treatment, right? And figuring out how to make recommendations that that consider that as well. So that's one thought. And the other is thinking about actually what came up in the previous session regarding Alzheimer's disease. I mean, wouldn't it be amazing if we could cure Alzheimer's by 2040? And one of the reasons why we're really leaning in right now to rare disease with CRISPR is to figure out, as one of my colleagues, Fyodor Urnov, likes to say, the CRISPR cookbook. How do we figure out how to create a clear and easily implemented pipeline for diagnosis, CRISPR modality creation, And then implementation, and of course, this has to come along with these other things we talked about bringing down costs.
Starting with some specific rare diseases, but potentially
Starting
much,
with
can you say a bit
yeah.
much broader potentially? Or?
That's right, because one of the, and this is where Alzheimer's comes in. If we think about how are we going to cure Alzheimer's, and I'm the wrong kind of doctor here, but I think what we really want to do is prevent Alzheimer's. That would be great. What if you could use gene editing to give us all protection against a disease like that, a degenerative disease that has a very well-known genetic basis to it? And maybe that doesn't cure everybody, but I think it's a strategy that I think we have to consider, and that something like gene editing could get us there if we can bring these pieces together. It's a very exciting vision.
So precision diagnostics with evidence-backed more definitive interventions that are much more effective at preventing the disease from happening or progressing. So we're now coming to the point where this has been a great discussion. We're getting toward the lightning round. I do want to put you all a little bit on the policy side. Bob, you alluded to if we keep paying for services, that's probably what we'll get more of. And that seems different than what Jennifer was just describing, which is I think paying more for identifying risks really reliably, and then paying more for doing something about them and the supporting data and evidence to get there. Is that right? What do you all think is sort of just a last as we close out this session? Yeah.
Want to go to California?
We want to start with Bob? Yeah.
Well, I think Jennifer's vision is spectacular, and I'm hoping that therapy comes out quickly to prevent. I'm getting to the age where I think a lot about that. I don't know that the fee for service thing would be the obstacle there. If in some ways it's not been the obstacle for vaccination, for example. If we can come up with a therapy, the question will be, can we afford it? But that would actually prevent Alzheimer's demonstrably. The downstream cost savings would be so remarkable, and just sort of the ethical and moral mandate to do that would be so intensive that I don't think we'd need value-based care to do it. What I do think is an important policy issue is what is the incentive that the overall system has to keep people healthy? And, I work at UCSF. The place is a wonderful place. We're moral. We took the Hippocratic Oath. We care deeply. But will we invest in what we maybe should be investing in if it's going to keep people healthy out there as opposed to coming in and sick? Our incentives are all making sure we do the best job we can when someone comes in sick. And so I think if you want to turn the system to be focusing more on that preventive layer, and I think the thing that's really quite different now is in the old days, you hinted at this, but maybe to make it explicit, in the old days, the only way we had to measure stuff about patients, intervene, and coach and sort of motivate people to do what the right thing to do was in this thing we called a 15-minute office visit. And that will not be the way care goes in the future. In the future, you'll be measuring things. You will be probably recommending some interventions, and you will be having this opportunity to coach. Independent of this thing that we used to say, you go in the waiting room, read a Reader's Digest for 45 minutes, and then we see you for 15 minutes. So I think the whole world of primary care and prevention has got to change a lot, and some of that will hinge on the payment system, but some of it will just hinge on, does the technology get to the point that we can build wraparound systems that do all this effectively? And maybe the last point I'll make, Mark, is about primary care. I think there will be primary care, but I don't think you're going to need to see a primary care doctor to manage your cholesterol and manage your high blood pressure and maybe even manage your diabetes. I think we will figure out AI-enabled ways to get those sort of things that are pretty algorithmic done. But then it has to be connected to a system where you, patient, need to see a doctor because your issues are complex enough and that you need a real human.
Karen, how do we get to payments regulation in the near term that moves us in that direction?
Well, I applaud the administration's work on access to try to have IT implementation be deflationary. So that's a good start to think.
This is paying for a new class of digitally forward providers based on how well they identify real risk factors and reduce those risk factors according to evidence. That is not fee for service.
That's right. It's a way of thinking about technology as a tool like your stethoscope, just to be reductionist. So that's a good start, I think, and in my dreams, we would get to global budgeting for everyone's healthcare, but I'm pretty sure I'm going to die before that happens, and we'll be doing fee for service forever. But
You should talk to Nina Sefamani on
I
that.
should. Ideally, that's where we go, because we're paid for outcomes. But I think just to this point about, so the payment, and I don't mean to be flippant, the incentives really do matter. And I do think it's a problem globally, especially because there's this expectation of set pricing that we get in the US. It's a complicated system, but all over the world, with some exceptions, like in India and Japan, technology can be deflationary if you're competing more on price as well as access. So that's a different panel. So keep working in that direction, but I'm less optimistic. But what I am interested and optimistic about is the consumer pull to have primary care in their pocket on a phone, and the potential there. It's not ready yet, but I do think that there's some components that could be particularly useful. I think we need to allow ourselves, as people who've been in the healthcare system a long time, to own that we have a very traditional way of thinking about how healthcare operates, how science operates, and we're going to have to allow ourselves to let go of some of that power, some of that knowledge, and share that, and sort out what's the new way that we can get to population health. And I feel compelled to say this. Two things. One is that if people are engaging with Gen AI as their first point of contact, 30% of the population is now already, so it's not a big leap. It's doubling right every year. There may be ways to detect early cognitive decline from the Gen AI model long before you show up in the clinician's office, right? To get to this prevention point. So there are lots of ways that we should be imagining that we could help prevent disease, much less treat disease. But in 2020, you won a Nobel Prize for chemistry. But in 2025, the Nobel Prize was won by AI, essentially. Yeah. And so as we think about, that's exactly right. They're not just chemistry, but physics as well. And if we think about how fast this technology is changing fields in science, it could also change medicine if we embrace that, I think, and we could do it in a way that's really going to help improve health of individuals. But it will require, I think, some sort of letting go of our traditional ways and of our power.
So Jennifer, you get the last word on all this. So you were a pre-AI Nobel Prize winner. So this is AI for sort of discovering and bringing forward treatments that look really, really promising. Back to where we started, you still got to show, at least based on the technology we have today for clinical development, safety, effectiveness, and as we just talked about, integrating into practice. Are these bots that people are increasingly using and trusting? Are they worth the trust, and how do we convey that? Any last words about the evidence challenges here?
Well, there's no question that AI is absolutely accelerating everything, in my world as a, very fundamental scientist. It's increasing the pace at which we can, design hypotheses, figure out which experiments to do. I always tell my own students, we're going to use AI to tell us all the experiments we shouldn't bother doing, right? And focus on the ones that are most likely to be interesting. And then, of course, there's all the downstream interpretation of data, et cetera, that's happening also very fast. And I know that, pharma companies are obviously employing these types of approaches as well. So that's accelerating, and I don't think we're going to see a deceleration anytime soon. So the question that I have is, how we're going to use that effectively. I don't think that we're going to get rid of the need for scientists. Maybe that's wishful thinking, but I don't think so. I think we need scientists, but we need scientists that are savvy about how to use these tools and technologies, and how to be a little bit skeptical of these technologies. No offense, Karen, but I think, right? And we have to be
skeptical's good.
Careful about what kinds of outcomes we're getting. And I think that's true whether we're a scientist working at the bench, or frankly, whether we're a health policy expert who's looking at aggregated data and trying to predict patient outcomes, right? There's going to be a level of sophistication that's going to be required to interpret that in a smart way.
Next generation of clinical trials, clinical development, and Karen, as you and I have been talking about for a long time, learning healthcare system. Yeah. I want to thank all three of you for a terrific discussion to kick us off today.
Everyone, I'm Rebecca Whitaker. I'm the Research Director for North Carolina Healthcare Transformation at Duke-Margolis. And I'm really excited for this next panel focused on the path forward for state and rural healthcare transformation. So I'm joined today by Bruce Greenstein, who is the Secretary of the Louisiana Department of Health. He's the former Director of Strategy and Innovation at the nation's largest post-acute care company, ran Microsoft's Health and Human Services Business Division, and served at CMS, overseeing Medicaid managed care and waivers and demonstrations. Next to Bruce, we have Meena Seshamani. She's the Secretary of Health for Maryland. And under her leadership, Maryland has emerged as a national laboratory for healthcare innovation. So we'll get back to that global budget reference you had in the previous panel. Meena is also the former Deputy Administrator and Director of the Center for Medicare and the Centers for Medicare at the Centers for Medicare and Medicaid Services. She's also a board-certified head and neck surgeon and health economist. Next to Meena, we have Rajay Bhatniji, who is co-founder and CEO of Waymark. He's a physician and entrepreneur passionate about improving care delivery. And at Waymark, leading a team that is catalyzing improvement in cost, access, and outcomes for people with Medicaid benefits through AI-enabled community care. And certainly last but not least, we have Dan Brillman, the Deputy Administrator for the Centers for Medicare and Medicaid Services and Director of Medicaid and the Children's Health Insurance Program. Dan is the former CEO and co-founder of Unite Us and a 17-year Air Force veteran. So we thank you for your service, Dan. I want to start our conversation today by acknowledging one of the real kind of foundational challenges facing the healthcare system right now that folks have already referenced it on earlier discussions today, and that is the increasing cost pressures across the healthcare sector. Affordability is at the top, healthcare affordability is at the top of everybody's policy priority list, right up there with gas prices. And so consumers are feeling this, payers, policymakers, providers are really feeling the stress from related to healthcare affordability. Of course, there are many promising approaches out there to get to better health at lower cost, including innovative ways to integrate key data systems. States have long been engines for innovations in health reform and in these spaces to drive better health at lower cost, including testing new Medicaid innovations through Section 1115 waivers, driving multi-payer initiatives to align incentives and reduce administrative burden, and advancing policies to support new care models that provide the right care for the right patient at the right time. But state leaders are very busy right now and grappling with a lot of challenges related to navigating implementation of Medicaid eligibility, financing, and policy changes that are flowing down from the HR1 legislation, as well as implementing their rural health transformation grants from CMS. So states are really looking for practical strategies and tools to scale and sustain innovation to achieve affordability and access goals, recalibrate Medicaid infrastructure and budgets, and capitalize on the opportunity of the rural health transformation funds. Duke-Margolis, like a lot of other organizations, is helping support these critical efforts through our National State Rapid Learning Collaborative, and thank you all for participating in that, as well as a range of programs in North Carolina, which provides a forum and resources to identify and spread innovative approaches to making Medicaid more sustainable and impactful, particularly in areas related to digital health and technology-enabled care, and payment reforms to increase access, affordability, and whole person care. So this panel is really aiming to provide some good concrete ideas of where we can partner more with our federal colleagues at CMCS on priority reforms, as well as opportunities for cross-state and public-private collaboration to accelerate getting to scale and sustainability on these needed reforms. So I'm going to start off coming to you, Dan. And, again, acknowledging states are facing real pressures from healthcare spending growth, new federal requirements. One path that states can take is certainly just kind of slimming down on eligibility and benefits. But you've talked about a different vision. And so as we kind of look ahead 10 years, our theme for the conference today, what should a modern Medicaid program actually look like for patients, providers, and states?
Yeah, so thanks for having me, and know many of you out there as well, because not long ago I was one of you and wasn't wearing a suit. And so I understand, one, all the complexities of Medicaid and how we serve now 80 million beneficiaries on the program. And so if I take a step back, we're spending now, Bruce and I were just talking about it. I mean, $1 trillion that we can even count on this program. And that's going to continue to increase. We're going to spend another $200 billion a year over the next 10 years as we continue to grow the program. And we're getting less and less value because the stats tell us that. Three-quarters of our beneficiaries have one chronic disease, 33% have 3 chronic diseases. And so if we think forward, there's kind of 3 main things. And coming from the private sector, I don't just want the same thing, but a small different changes, because that's not necessarily going to get us there. And so the first thing is, how do we actually, and you'll talk about this in your great work, and Mina's doing this in certain ways, how do we align spending and value in the right way? Right now, we were trying to quantify, before we got on here, how much is actually getting to the beneficiary, to the right things that actually matter and move the needle. We cannot quantify that, and that's a problem. And so, 75% of my business and our group is in managed care. And those were my customers before. And I think both them and we are thinking about, what is managed care 2.0? We call it managed care, but are we truly managing prevention, chronic disease, upstream drivers that actually get to the root causes of issues? And are we paying for those things? The answer is no, we're not. And that's a big problem that we have to think about with the private sector. I wouldn't do these things without knowing what are the carrots and sticks and how do we align incentives, because that's what this is all about. The second one, and when I came into this job, my federal staff definitely gave me a little bit of crap for this, but I said, hey, we really need to get into streamlining the program's design and operations. And for those, he's running a business right now. I ran a business before. Scaling in Medicaid is very hard. Scaling any program, a care delivery model, a technology, is very hard because there's 50 different programs with 50 different designs. And that's also a problem. We keep spending more and more money to customize the program when really we can streamline the program in 2026, where we're all doing about 70% of the same thing. We're just doing it all differently. And that's something that we really need to get states and governors and Bruce over there, which he's on board, aligned with. And that goes for things. An example of this is quality measures. So quality measures is ultimately what drives payment. And a plan yesterday gave me 4,000 measures that they have to track, which is between NCQA, Child Core Set, and then states develop their own measures. And then if they're managed care plans, develop their own measures for their providers. And that is a burden on everyone. And that's not ultimately, most of these are just activities. They're not actually outcome-driven payment. And so we need to measure fewer things so that we can actually focus on what actually matters and pay for the things that are truly driving better health outcomes and actually lower costs. Because we focus on everything, we're literally focused on nothing. And then I'll talk about technology as we go through here, because that's going to be the underpinning of all this. We can't keep adding more people to the problem. The last thing that I hope we take this opportunity around what we call community engagement that is going on live next year is really focusing on paths to prosperity. I did a lot of work on this in the past, is actually how do you wrap around the person and improve their economic mobility? It's not around how do we meet a requirement and a compliance, but actually how do we take our sectors that are all serving the same person over the same period of time or at different periods of time and work together around that. Labor, think about all the gaps in care that people have outside the 4 walls of the hospital, how to use technology, actually coordinate that in real time. That's our opportunity. And that's a fairly bipartisan thing. If we can improve economic mobility where people don't need Medicaid, I think that everyone wins that battle and everyone can agree with that. And the last thing I'll say, everything needs to move into a technology-first approach. No offense to states, they were my customers. Bruce is one of them, but he's not 50 of them. He thinks about technology first, but it's very, very hard. And I'll leave you with, I spend now $20 billion a year on Medicaid technology, and I give that to states and match 90% of that. And what we've gotten for that is changes to systems. We have not gotten incremental improvements or massive improvements to systems. And this is our opportunity with me in the seat to really think about how do we use technology differently? What do I pay for? We should be paying for things that actually are driving both accessibility, better coordination, and real-time data exchange, not just talking about it. And the way I get to that is by also reading every single proposal that comes in. And no one's ever done that in my seat before because no one's ever said no. We just say yes. in the past. And now it's a different way to say, what tools do you actually need to combat fraud, waste, and abuse? What tools do you need to focus on prevention where an agent can be there before a doctor has to be there? It's very expensive. And so those are the things that ultimately we need to drive for. But what I need your help with is your ideas, because I don't have all the ideas to get there. And I need states on board, and I need all the providers and payers to be aligned with me as well.
That's great. A really helpful vision and call to action as well. So I might turn to the other panelists here and give you an opportunity to react to what Dan's saying, what's really resonating with you, and kind of where from the places where you sit. I mean, I don't know. Yeah. I'm looking right at you.
Sorry. Well, it's great to be here with all of you. And I think one of the things that I'll pick up on from what Dan talked about is having that technology first approach. So in Maryland, we have stood up Maryland Benefits, which is a one application platform, so that all of our various programs from Medicaid to SNAP, LIHEAP, TANF, there is one avenue, one portal. You can access it on your mobile phone that takes you through a universal screener. So there's no wrong door, and you can apply and go through your eligibility and enrollment process. We are leveraging that for the changes that are coming with HR1. I think, as you all know, a lot of the churn that occurs in Medicaid and a lot of what studies have shown with prior policy changes, with work requirements, et cetera, is that people just have difficulty navigating through the process. And it's hard for people to be able to go to this office and then that office and then collect this paper and that paper to be able to enroll in programs. So this presents an opportunity for streamlining of our work, automating as much as possible so that people who are eligible to stay enrolled can stay enrolled. I mean, we estimate that in Maryland, absent, making some of these changes, we could have, 115,000 people lose access to Medicaid coverage. And not necessarily because they don't qualify for Medicaid, just because of the natural churn that is in the system. And so we're really looking at how can we optimize and automate our systems? How can we leverage? We have one of the best health information exchanges in the country through CRISP, where we get data on people through all avenues of care that they walk through in the state of Maryland and also in adjacent regions. So that is a great way to collate information on people for things like the medical frailty exemption, and to understand leveraging the National Student Data Clearinghouse so that you can automatically identify who is in school, and being able to use those kinds of data and those kinds of tools to automate the process for determinations and redeterminations for Medicaid. And that hopefully is something that then, again, because we have one unified platform, it's not just for Medicaid. It's also something that we can use for SNAP. And we are working very closely there, where we can then also leverage that technology for other programs. Because ultimately, what we want is for people to be able to navigate the system to get to the benefits that they need. And then that enables us to then also utilize that data to be able to target how best we serve those people, which I know we're going to get to later.
Yeah, I really appreciate that. Rajay.
Well, I think what we heard from Dan were really 4 priorities, which interestingly, I think you literally cribbed my notes, because those are my 4 priorities, which are, first, moving toward value and actually capturing value for Medicaid where it's sometimes been missing. Second is actually scaling what works and doing it nationally. And I think the reason that that's often failed is that, the programs that really worked were done by local heroes that figured out how to cobble together the system, how to get the data to target the patients, how to do the intervention, and they wrote it up, and then that was it. Nobody's ever built the true product for scaling that nationally and making it reproducible. And they talked about thinking about the whole person and not just the clinical care delivery, but their food and their housing and their social needs, because that's often what drives their clinical costs. And then finally, using technology to enable us to make this highly reproducible. I'll maybe go back to the first point on aligning the outcomes, because this has probably been the area over the past year for the greatest shift for us is, we're doing Medicaid community-based care delivery that's automated by technology. And one of the things that we always do is like a core ethos at our company, Waymark, is we publish everything that we do, every experiment that we run, because we are building on the foundations that others ahead of us have already laid. We did not invent the idea of community-based care. We did not invent the idea of meeting social needs. But what we're doing is we're actually scaling it in a way that it's never been scaled before and with consistency with which it's never been applied. And so because of that, we literally publish everything. We over the last couple of years, over 30 peer-reviewed papers showing exactly what works, how it worked, why it worked. And that orientation led us over just about a year ago. We went and said, well, what if we actually structured all of our contracts as real-time randomized controlled trials? Because we showed in our RCTs that these programs had an effect. And what if that was actually the contract design when we work with a health plan or even a state in the future? And that's what we've done. And so when you think about kind of aligning to outcomes, can we do that in the most credible way possible so that you're not just making a claim, but actually making sure that as you deliver on that claim, that's what enables you to do more and more of it. And I think that's obviously in the interest of taxpayers for ensuring our funds are used responsibly, but it's also in the interest of actually scaling what works. Because if that's the ultimate aim, and I think it is the ultimate aim for many of us in this room, I think there's no better model for doing that. So, thank you for having my exact same talking points, Dan.
And coming to you, Bruce.
Yeah, so I'm the execution layer of the CMS policies. And when the topic of the discussion is what do we look ahead for the next 10 years, and it's probably helpful to look back 10 years or 20 years. I used to work for Mark, and we both worked for Mike Levitt 20 years ago, and he gave a speech on value, moving to value. And at the time, he always said, we're 5 years into a 25-year journey. And if you've heard his speech, it keeps changing. And we're 15 years into a 40-year journey. The reality is we just really haven't made that much progress, despite all the activities. And so when you think about Medicaid has eclipsed $1 trillion of expenditure. I just looked this morning at the 2024 CMS actuary total expenditure, and it was $957.1 billion. And it had the number of people that were covered. If you do the division, it comes out to be $12,065 per person per year. That's far more than Medicare spends on its entire population for a much less sick population. So what's happening to the Medicaid program? It's become sort of a piñata for myriad interests, especially at the state level. We didn't really envision that Medicaid would be funding beyond healthcare back in 1964, 65 when we envisioned the program. But now schools, prisons, homeless, food, all become benefactors of this social program that really doesn't have a stopping point. So you opened up saying, we're budget pressure and are we going to slim down benefits? No. Unless we have a serious recession, it doesn't happen. No one comes to the state capitol and say, you know what? We get paid plenty. Why don't you reduce our rates? Or you know what? Medicaid's so big, let's have fewer benefits. I think when we think about what the next 10 years looks like, I have a couple of practical items, but I think we have to think about system-wise. We work under incentives. And those incentives have really played havoc with trying to move to value. We talked earlier, Rajesh and I, there's a reason why there's not as much value-based programming going on in certain states around the country because hospitals don't want to reduce hospitalizations. We pay very well with supplemental payments and a variety of other add-ons, and we measure hospitals with additional supplemental payments by the amount of claims and the claim volume. So there's really not a brake rubbing on the rim for reducing hospitalizations. We know the engineering side of me, we would always say that a system is perfectly designed to produce the results that it does. Why are we ever surprised that our system looks the way it does? And so if we're going to really make an impact, we have to change the whole structure and the incentives. States are really good at going where the money is and then figuring out how to spend it. As Dan mentioned, technology, the nation, states spend a lot on technology. We have a 90-10 match. We pay only 10%. So we're not price sensitive at all. We're not very good at managing scope creep, the budget creep, because we only pay 10% of the total cost. they pick up the rest. And so we get a marginal product, oftentimes an over budget. And when it comes down to managed care, we have figured out how to basically privatize a fee-for-service program, have now distributed administrative costs in the private side, and our own administrative costs have never gone down. We never come to you with a lower 50-50 match on administrative costs. So all those areas add up to some things that we can do, which is one, we need to be able to bring better expertise and leadership inside of state governments to execute at a much higher level. We get outgunned everywhere. The health systems have better lawyers, the managed care plans have better actuaries, and state government tends to pay somewhere around 65% of what you would make on the commercial side at a given rate. I think the transition will come from being spurred on from CMS, because at the end of the day, our interest groups, be it whether it's managed care, hospitals, other providers, still know what's possible and don't want the bureaucrats to leave money on the table. And we would be doing that otherwise. So we applaud the administration's interest to reform the system, to make it stronger and better, and also to focus the considerable cost. I haven't been asked to spend less, but just spend it wiser and get better outcomes from it.
Yeah, absolutely. That's point around aligning spending with value and really emphasizing that. I want to come back to the point, Mina, that you were raising earlier, but coming to you, Bruce, around the use of technology. Louisiana has really been an innovator in deploying technology and an early adopter of the Eligibility Made Easy, or IMME, so one of these open source tools that CMS is developing to help streamline income and community engagement reporting for Medicaid applicants and enrollees. Other states are starting to explore the use of these tools. And as we think about deploying technology in new ways, what has this experience taught you about how states can use technology to manage programs more efficiently?
Great question. When it comes down to implementation of HR1, there's been a national freakout session that's predicated mostly on misinformation. This is not something that's going to eliminate half of the Medicaid population or make it impossible to get Medicaid services. First of all, the use of technology is just part of our overall portfolio approach. We get changes to Medicaid happening all the time. This is well within our scope and well within our lift. We started right away, though. July 4th, the bill was signed. By July 10th, 11th, we were already working, getting work groups together, adopting technology and assessing our own capabilities. So using technology is part of us just being efficient at doing our job. We started out with understanding what the lift is. At the time, we had 1.64 million people on the Medicaid rolls. Today, it's 1.481. We're at the lowest level, by the way, since 2016, and we have 0.1% lower uninsurance rate than we did at that point, too. So we're doing a very good job of coming off of COVID, making sure people have health insurance and have access to good health care, and then also taking care of our own processes along the way. So I'll just go through the numbers. 1.48 million people. When you take out those that work requirements are not applied to, say kids and moms, caregivers, et cetera, then you take out the slice that is medical frailty, and then we start working with our own technology. And we know medical frailty automatically, almost all through claims data, and those that want to attest that there's a medical frailty when it's time for determination, then we'll go through that process and we'll use claims, or we'll use basically a doctor's note after that. But we come down to only 66,000 out of the 1.481 million people that we're really concerned about. The others that this applies to, we've already indicated that they have enough income, and we do that through electronic tools. Emmy is one of them through CMS. We were early adopter of CMS's free technology. That's better than 90/10. It was zero for us. We've been testing it and providing feedback, and it allows individuals to basically have their own payroll data come directly to us. We don't have to ask them. We just run it through our system. We use our own Department of Revenue data. We use proprietary tools that bring in information about where they live, their income, and their household composition, so we can do all this without even asking them. We look at the income for those that have enough. We put them to the side. We have a lot of people with incomes that are not eligible because their income is too low, meaning they haven't worked enough hours. The vast majority are tip workers, so we have to remind them, hey, you need to pay taxes on your tips too. That will come through when we go ahead and do the determination, and it leaves us with 66,000 people that we're already concerned about. So it's May right now. Last Thursday, our first letters went out. Letters, then next week we'll do postcards, we'll do email, and we'll do text messaging where we have cell phone numbers. No one is not going to hear from us. We want 0 people to lose Medicaid because of a complicated or a cumbersome process. We want a lot of people to move off of Medicaid because they have great jobs in Blue Cross or Aetna, Cigna, they have private health insurance, and they're moving on with their life. Our goal is not just the Medicaid program. Our goal is to see people move from dependence to independence and really meet their full potential for them and their family and their community. And these programs allow us to do that. We're blessed with below national average unemployment, so there are jobs. We think about Medicaid as an opportunity to help match people to work opportunities, and we're going to supply a lot of assistance, whether it's in resume building, application writing, orient on how to apply for jobs if you've never had one before. All of this rests on the technology platform and makes our job a lot more efficient.
Yeah, and I think, drawing on a couple of things that you were saying there and tracking back to what others, if you've identified these 66,000 people doing really targeted outreach to ensure that they're, have the assistance that they need to navigate the system and retain coverage, which you were touching on earlier, Mina, and then using tools like Emmy where they can sort of interface and upload the required documentation. But Dan, kind of going back to your point around pathways to prosperity, kind of using the investments in data and technology here to create those wraparound services. So it's not just, maybe there's an opportunity to identify folks who are kind of at rising risk of maybe needing additional employment supports. And how does that, then interface with these tools? I think I'm going to use that to transition to you, Rajay, and thinking about, if one of the themes that we're talking about today is really shifting upstream, not just managing eligibility or healthcare utilization, but thinking about whole person, prevention-oriented care that focuses on non-medical drivers of health, like food and housing and transportation, but also care coordination, primary care. You've worked with a growing range of states and Medicaid health plans to use better data and methods to identify individuals who are at rising risk of worse or more costly healthcare complications, to identify the available services and supports, whether they're medical services or social services, that are most likely to lead to better health outcomes for these folks and lower healthcare utilization and spending. So if you could tell us about the model that you've built at Waymark, including how you've generated and integrated evidence to refine your model. You touched on this a little bit already with the RCTs kind of built into the contracts and really being transparent about the evidence that you're generating. But how can states learn from your work and rapidly evaluate innovative programs to validate and sustain these efforts to advance budget neutrality?
Yeah, absolutely. I'm happy to share more. And I think, Bruce, following on your discussion about the use of technology, I think there's a really important element in the use of technology for, handling a lot of the procedural tasks. And I think that's almost the first piece that everybody nibbles off, is, whether it's enrollment or finding eligibility. But where we focus on the use of technology, and frankly, I think the greatest opportunity in AI for healthcare is around improving access to care. And specifically in Medicaid, that's a huge opportunity because that's where access is the most challenged. And so, I think that is the reason for so much inefficiency. And actually, one of the papers our team wrote a couple of years ago, we showed that actually 40% of acute care utilization in Medicaid met the definition of avoidable, which interestingly is 3 times what it is in Medicare and 3 times what it is in commercial. And so you have so much expensive and avoidable acute care use in Medicaid for the simple reason that people can't access primary care, they have unmet social needs, and that's why the opportunity is so big. And so if you kind of ask, like, well, how do we do it and what do we do? I'd say it's really 3 steps. The first is identification of opportunity. And so you mentioned the phrase rising risk, and that's one that we think about a lot. And specifically, what we're talking about is which patients are most likely to end up in the ER or hospitalized in the next 60 to 90 days. And we trained on the National TMSIS database and have published a series of papers on this showing that we've got about 90% accuracy at predicting those future acute care utilizers. And then the question is, well, what's the next best action for those patients, and what's the next best intervention? And often this is where things get lost, is you might identify, here's somebody that really needs help, but then what's that next best action? What we recently published this paper in JMIR, which is showing that actually, our care team members, when they follow the AI generated next best action, had about a 20% relative, 12% absolute further reduction in acute care utilization than those care team members that followed the predefined playbook. And so you can actually be pretty precise about what the next best action is for a specific patient and feed that through. And so there's this kind of universe of identifying where the opportunity is within a large, broad Medicaid population, which patients need the help, what exactly is the intervention that they need. The next step is outreach. And this is, you talked about mailers and phone calls and text messages and all of those things. And we're doing that outreach, obviously automated first, and then where automated doesn't reach somebody through text message, AI voice. Actually, then literally, we have community health workers on the ground that will go find that patient in the ER if that's where they are, or at their home, and actually go out and reach those patients, because we need to make sure that we're reaching everybody that we can help, because we know that the ROI on that's going to be incredibly high. And so that AI guided outreach, but with human support. And then for us, the last stage is really the care delivery stage. And so for a lot of patients, what we're able to do for them is identify this patient really needs a primary care appointment, and we can schedule that for them. We can identify that here's a patient who hasn't picked up their diabetes meds in 3 months, and we think they're likely to end up in the ER or hospitalized because of that. And then we can actually have a pharmacist that makes sure they get that medication. But sometimes the answer is actually, here's somebody that really needs clinical support, and it'll escalate. We'll escalate this to our care teams and make sure that that patient talks to a community health worker, will accompany them to a physician's visit, and really get them plugged into healthcare. And so for us, it's that kind of end-to-end process. And what we see and what we published is and we're not the first to show this. It really works, right? I mean, we published in New England Journal of Medicine Catalyst that we're seeing about a 23% reduction in acute care use compared to a matched cohort for those patients that are engaged, and that more than pays for itself. And to me, a big part of what technology does, and the reason that we've leveraged it is it makes this process radically more efficient. And so if you didn't have precise targeting and you were using kind of common risk algorithms, the best algorithms have about a 30% accuracy at predicting future acute care use. If you get that up to 90%, that means now you're reaching out to many, many fewer patients who won't benefit than you would have otherwise. And so you can really bring the cost to serve way down. I mean, even in our own, years of operation, we're seeing that, already reduce over 60+%. And I think there's pathway to further reducing that. And so you can make evidence-based interventions that were already cost-effective, just radically cost-effective through the use of technology, through AI, and really use AI to automate what we know works, and use AI to actually, reinforce and make it scalable solutions that have been proven.
And I want to come to you next, Mina, to dig into some of the innovative things that Maryland is doing around total cost of care and affordability. But Dan, I wanted to come back to you very briefly, and as one of the charges for you right now and working with states around 1115 waivers and budget neutrality. And so as you're hearing sort of these comments from the other panelists and from Rajay and sort of the approach there, What are you hearing and how you would like to work with states and private sector partners on strategies to advance innovative and budget neutral coverage?
Yeah, so we're using this term budget neutrality, so it's good to talk what that is. So in 1115 are waiver demonstrations that states can test and innovate new ideas, and these are 5-year periods typically to do that. And it's ebbed and flowed through different administrations on what they're going to test out. And so over time, that's gotten a little bit, in my perspective, because I was on the other side, as a technology provider, it got a little bit out of whack in the context that lots of states were doing these things. None of them were talking to each other. They're all doing it differently. And at the same time, the end goal was to prove that we're improving health outcomes and lowering costs so that we could go to talk to Congress and ultimately make those benefits, right? And so that's the intention of 1115. And so through that period, lots of new things came about where we're talking about health-related social needs and doing that work. And there's great examples where it's worked really well. Some are, continuing. I see North Carolina people here where they've already proved that it works, right? They're saving $1,000 in their first study, and they continue to stay on that program. They continue to spend less. They go to the hospital less, and they're better off. Back to the problem that I said, and my middle part of this is streamlining the programs, design, operations, is that a lot of people went and chased to these 1115 models to get this work done. And that is not the end state. These are 5-year things. If we're trying to make this a 50-year thing that we're all going to invest in, it's got to be sustainable in nature. And so what people don't realize is that there's 19 different ways to also address these problems inside of the Medicaid program. In lieu of services, this is driven inside of managed care where it's programmed inside of it, value-added benefits. 1915 waivers are different waivers that target these same interventions, different populations. So part of that is there's other avenues to be able to start doing that. And then 1115 specifically, from my perspective, should be used for distinct innovation that can be scaled, that states should adopt the same way. North Carolina's doing it well. Everyone should do it in a systematic way where then ultimately they all can come together with their congressional staff and their legislative staff to say, by the way, this worked 50 times, right? Versus it worked one time and then you don't know what's going to happen. And I'm sure that's a challenge for you, right? In your business where it's working every time he's doing it, but are you in 50 states doing it every way? And so as we take a step back, one of the big things around, whole person care is that this takes it's a multi-sectorial approach. And that's not an 1115 thing, that's a Medicaid thing. And so first we need the foundation of how do we actually coordinate better between the sectors. We have our own problems in government. I'm trying to unlock that. I'm like, how does labor work with SNAP? How does SNAP work with, other agencies together? Because it's the same person consuming all those benefits. I mean, you've done that at a state level, federal level. We need to get out of our own way too and work together better. And that's what I'm trying to unlock so that states can actually do that better in practice as well. So taking examples like community engagement, SNAP and Medicaid, we're going to help build APIs where it doesn't exist, right? Or I negotiated that with some of the vendors to do it for us in those states so that we can get systems even talking together. Medicaid, ultimately, we need to be the payer of last resort because there are a lot of other resources first, right, to take care of, to be able to do that. Otherwise, we're duplicating services and we're wasting more and more money, not just in the Medicaid program, but across different programs. That's the first foundational layer. And then, okay, if we deduplicated between other agencies that already do some of these services, what should we be paying for? Healthy foods, right? Specific types of housing benefits, and then make that very clinically oriented so that it's very effective and very cost effective. So I'll give you a really good example of how I think just math equation sitting here as a regulator. So if you have someone sitting in an inpatient stay for 11 days and you can't discharge them because they're homeless, what do? Right? And do you need an 1115 for that? These are simple math equations. If you can get that person housing in, outside of the hospital and you can discharge them faster, we're not spending $10,000 a night for an inpatient stay, right? These are just math equations where it might be easier and faster if HUD is taken up, maybe we should pay for that, right? That's just an example where it becomes a math. When we get too large, then we're focused on nothing because we're trying to do everything. The last thing I'm going to say is when Raj talks about his evaluations, he's very precise in who he's targeting, right? And the population that you're targeting. When we focus these things on Medicaid, we're trying to prove them in an 1115 context and budget neutrality. We need to make sure we're getting to the populations that's going to affect the right result. And that means if we're from a federal government perspective, if we're trying to standardize this, we need to be more prescriptive in who we're going after, how we're going after them, and the services we're actually going to deliver for them. And that's just more important for us so that we get it right and do it well from a national perspective and take the best learnings that's already been done and be able to effectuate that and try to get out of the silos of let's fund this, when ultimately it's the same organizations doing the same things over and over again, just different pockets that ultimately I call it wastes money in the end if you're not really bringing the sectors together in the right payment approach with the right people at the table.
Yeah, and I'll give on that. Duke-Margolis is collaborating across public and private partners, including, working with you all at CMCS, state leaders and private innovators as well, like with FoodSmart, trying to think about what is the evidence and all the different regulatory authorities that can be leveraged in addition to 1115s and the evidence kind of pushing toward budget neutrality. So more resources coming out soon in that regard. But Mina, I want to turn to you next, and then we'll do a lightning round around rural health transformation, because I want to make sure we get to that today too. Maryland has taken one of the most ambitious approaches, and Dan was talking about sort of the journey of 1115s and other Medicaid authorities, but Maryland's taken one of the most ambitious approaches to healthcare affordability by advancing statewide total cost of care accountability, now part of the CMMI Ahead model. What does it take to move from fragmented payment systems to true population level accountability? And where have you seen that make the biggest difference, and including any kind of key opportunities and challenges that you all have experienced? I think you touched on the HIE earlier as one of the great investments that has really facilitated this work. So,
well, and our HIE actually comes from the Maryland model, because ultimately, if you have alignment across all players and across all payers and across the health system, that's when everybody is rowing in the same direction, where it really matters that you can get data of wherever someone goes, because ultimately you are being held accountable for their cost, so that it is not, okay, I need to get a head and a bed in the hospital because that's how I, stay whole. It's about, no, we really are about managing to a budget and managing to healthcare quality metrics. So in the prior iteration of the Maryland model, over a decade, we saved the Medicare program $1.6 billion. And we met our quality metrics, had lower than national average for readmissions. But I think what is key about that is that savings of $1.6 billion wasn't squeezing one end of the balloon so then the other end opens up, right? Because otherwise, you have other programs that if you are not engaged in a similar way, there's an opportunity to make up for that amount. And instead for us, when you take $1.6 billion out of Medicare, you are taking $1.6 billion out of the entire healthcare system. And I think that is really important to remember. So coming back to what several of you have said, and Karen DeSalvo should just move to Maryland so she can live in global budgets. But I think there is a tremendous opportunity for scaling, not just across states, but across business lines and across markets, right? At the end of the day, ESI, employer-sponsored health insurance, is still the #1 source of health insurance in our country. And we need to make sure that the commercial market is engaged in these kinds of innovations. And that's where the power of an all-payer model like Maryland has comes in. It's enabled us to take money that would otherwise sit in paying for a hospital admission to instead now pay for food as medicine programs. We're doing medically tailored meals for diabetics who get admitted to the hospital and screen positive for food insecurity. And again, to the point that's been raised, then that's not just a test of something in one payer, it's across all of them. And so then there is that opportunity to move across all of the payers that I think is very important. But I also want to come back to something that you all have been talking about. It requires a different way of approaching how we are innovating in care. Because if you just think about innovating through an 1115 waiver, or if you just think about innovating, through Medicare, you're actually missing the boat, because again, you're just squeezing one end of the balloon. Another end is going to pop open somewhere else. And to the point that you made, Bruce, starting off with where some of our providers are, right? Right now, there is a lot of uncertainty, a lot of people feeling chaos, feeling disruption, a lot of changes coming really quickly. Now is a time when stakeholders can say, okay, I'm going to weather this by digging in my heels and being in my corner and doing things the way that I have always done them, because that is what's going to get me through. Versus, okay, there's a lot of change coming, so now is the time for us to actually think about doing it differently. But that only works if you have alignment. If you have alignment between not only the public sector and the private sector, but between federal and state government. Because otherwise, everyone's going to take the way the market works, everyone takes the path of least resistance where they can get the money. And so it is really important, as we are talking about changes to how we are going to really evaluate where money is being devoted and can really smartly produce the kind of healthcare outcomes that we want, that we are really thinking about the co-development of that among regulatory bodies, not just between like HUD and CMS at the federal level, not just between my Department of Ag and me at the state level, but between the federal government and the state governments. Because every state does have different flavors to their markets. And if you don't have an awareness of that, you just end up squeezing one end of the balloon and another end is going to open. So I think that is really going to be the key as we move forward. And that is something that we have had success to this point in Maryland. That's why I go places, everyone's like, oh, I wish we could be Maryland. Well, there are opportunities. And I do think that it requires having that alignment, not only on the regulatory side, but now leveraging the disruption that we are all experiencing to say, okay, how can we do this differently? Because I will tell you, when I was an intern in the ED, I did not want to have to take care of the patient who came in just to have a bed in the middle of the night. That's not why I went into training. And I think that we can tap into that, but it requires, honestly, it requires the leaders of our system to have that courage to come out of their corner right now. And that requires all of us having a drumbeat that we're beating together.
Absolutely. Well said. Yeah. You're getting, yeah, lots of applause on that one. All right. So I think we're going to do a very quick lightning round because I want to make sure we hit on rural health transformation. And I think it's actually a place that we can bring together a lot of the themes and points that you all have talked about in terms of you can't just squeeze the balloon in one place. You've got to innovate across the whole system. You've got to deploy technology in order to automate these processes and really generate the evidence so that you know what's working and transparently generate the evidence so that others can see what's going on as well. So 60 seconds or less, we're going to run down the panel here, and I want to hear sort of what is the top thing that you think states should be working on as they are standing up these rural health transformation programs. This is a 5-year investment from CMS, $50 billion going out to states. So pretty rapid timelines to implement and get to sustainability, but a really exciting opportunity. So Bruce, maybe I'll start with you and then we'll work. Dan, you can have the last word.
Yeah, first of all, I see Karen walking out the door. Mina, we're not giving up, Karen, from Louisiana. I think Mardi Gras beats global budgets for real. But so first of all, we're very excited about the opportunity to use the rural money to really do that transformation, which is part of the title. But remember, sustainability is what the goal is. And in reality, this is where this whole project comes into conflict with all the tenets that Mina artfully laid out, which is rural providers need more funding. And oftentimes, in our case, they're losing paying customers. They don't have enough patients. And so they do what they can to get more paying customers into their facilities. The ones that are doing well are figuring out how to be very creative, using their inpatient beds, say for swing beds or LTAC beds, using extra space for therapy clinics, maybe having their gym open to the public to pay to come in to raise funds. We're excited to revamp the way that we train clinicians and put them out in the rural communities in a very specific way. That's has already begun. We're doing value-based arrangements so we can sort of de-incent consuming volume as the goal just getting back to what Mina was saying, you really have to organize the system the right way. Otherwise, you're just pushing things around. We're making investments in companies that are doing interesting things that, due to economics, go to where there are more people in urban and suburban areas. We're going to incent them through payment or subsidy to go into rural areas to do those same things. And then we're also figuring out how to bring money to our providers to help them build for the sustainability, so do the transition from the model that they have today to the one tomorrow.
All right, thank you. Mina, over to you. And we'll try and stick to one top thing. Yeah.
One top thing.
Bruce gave us
I
four,
think
which is great.
the key for rural health in our country, the issues that people in rural communities have of access, of workforce, of disparities, they're not just a healthcare issue, they're a broader economic and societal issue. And so as we have been applying our rural health dollars, it's really been with that lens of how do we not only impact the health of our populations in rural areas, but actually lift the entire economy of those areas. So I'll give the example of the work we're doing in the food space. So I mentioned our Food is Medicine program. We're also going to be using our rural health money for overall nutrition education, produce prescriptions, healthy eating. But where is that food coming from? That food should be coming from the very same communities that we are trying to help to eat healthier. So we're using our rural health money to actually invest in our agriculture. So we're partnering with our Department of Agriculture to invest in food aggregators and food hubs and cold storage, so that starting with immediately, our local farms can provide that healthy food in their local community. But our goal over 5 years is that our local farms are then providing healthy food across the entire state, because we are then providing the infrastructure for that healthy food. And so thereby, you are addressing an immediate healthcare need, but you're doing it in a way that also lifts the entire economy of rural communities, which I think ultimately is the root cause of a lot of what we talk about when we talk about health disparities in rural communities.
Absolutely. Rajay, one thing.
One thing. I guess I'm going to stick to one, because instead of one thing, I'm going to propose a formula that we should think about, which is, look, this is 5 years of funding. It's not permanent funding. And so, Bruce, you made this point. Whatever we do with this money needs to somehow become sustainable. And so I would say here would be my formula, is identify what's already been proven to work, apply technology so that can be done with far greater scale and far greater precision than has ever been done before, and then make sure that we're measuring and aligning any of the payments associated with the program toward outcomes. Because at the end of that 5-year period, you will then have a self-sustaining program that can carry on in perpetuity. And I think that's the intent of this funding, is to create permanent change, not temporary change.
Absolutely. Last word, Dan.
Yeah, so I get to oversee this program, which is great. And I think the most exciting part is the transformation, and the fast transformation that states need to do. It's uncomfortable for a lot of them, maybe not these two amazing leaders up here, but it is uncomfortable how fast they have to move. But I think that's a good thing, because we have to not go back to the past, what Mina was talking about, because immediately you would say, just give me more money for certain things just to keep afloat. No, this is around how do we actually transform. We cannot add more behavioral health providers, thousands more into rural areas. So what are the other ways to do that, right? We think about AI and technology to be able to do that, to get access to the places that need it the most. The biggest opportunity for us, to all of your points here, is how do we take these learnings, and I know Duke is part of this as well, how do we take these learnings and turn them into things that are going to be applicable forever? And we're going to learn a lot, which is most important, but all states need to learn together. So there's maternal health models, behavioral health models, hub and spoke models. We hope those not are only transferable to other states and rural areas if they're not doing them, but they will do them, but also to urban areas. We're going to learn a lot that's not just going to be in rural, but the opposite effect, where we can transform this from a technology perspective. But what we need is the private sector to also work together to say what's working well, what can be applied across the country, and continue to advance those, so that 5 years from now, these become permanent things that are part of normal, ordinary business for every state.
All right. Well, as you can see, we could have talked about these topics all day. Thank you so much for all of your insight and your thought leadership. The work that you all lead has never been easy, but it's also never been more important in making these investments to help patients and families really have the resources they need to achieve their health. And as you all have highlighted, it's not just one solution, but really a combination of things, including aligning incentives, really targeting the right folks, using technology and data to deliver care more precisely and preventatively, and of course, evidence. So appreciate the collaboration and the partnership and looking forward to more good work. So thank you.
All right. Good afternoon. Thank you. All right, we have a few folks still coming in, but we'd like to go ahead and get started. Marianne Hamilton Lopez, I'm a Senior Research Director at Duke-Margolis, where I oversee our portfolio focused on biomedical innovation. And just wanted to start with just acknowledging, as we've heard throughout the day so far, is that we're entering an era where the transformative therapies are becoming more common. And what we mean there is whether it's your GLP-1s, which are becoming quite disruptive as far as drug spending, but also with health outcomes. We are also talking about these one-time administered, high price, but potentially curative and very personalized cell and gene therapies. What's also pretty clear is that our healthcare system is not yet aligned to incorporate these types of therapies into payment and delivery models. And so we're going to be spending some time with this panel talking through some of those challenges and trying to think through a pathway to more efficient and reliable path forward for incorporating these types of therapies into use. So it's my pleasure to introduce my panel. I'm joined by John Brooks, Deputy Administrator and the Chief Policy and Regulatory Officer, the Centers for Medicare and Medicaid. David Brailer, Executive Chairman of Health Evolution. Patrick Conway, CEO of Optum. And on the line, we have Dave Ricks, CEO of Eli Lilly and Company. All right, I'm going to come join us over here, but the way I'm going to get started, I'm going to start with Dave and David, and saying that, acknowledging that we're seeing these trajectories of more wider use, chronic GLP-1s, which have their own concerns perhaps about cost, about outcomes, about side effects and use. We also have the introduction of the cell and gene therapies, which we've discussed a bit today, but haven't seen not as widespread adoption yet, but are becoming more widespread. So what is it for the two of you, starting there? What does that tell you for the direction of biomedical innovation? And are our payment and our care delivery models equipped right now for that future that we're envisioning? Let me start with Dave.
Me?
Yes.
My head is the biggest? Yeah, okay. Great to be with you all. Sorry I couldn't be there live. We're celebrating our 150th anniversary today. So it's quite remarkable, and I had some duties here on our campus. Well, I mean, to your final question, I guess the answer is no. I think we're seeing lots of challenges with both these ends of the spectrum of sort of broad-based, very effective medicines like our tirzepatide or the newer GLP-1s that seem to do a lot of things for a lot of people, but we're having trouble with the funding equation through the normal systems. We could also comment on the delivery system. I mean, a lot of people are sort of self-actualizing care through new models, telehealth, digital, online, et cetera. We could argue whether that's a good or a bad thing, but definitely the current system isn't handling that. And then on the other end of the spectrum, and we have therapies in development for super rare eye diseases and deafness in infants and some brain diseases that are very rare. I think as a drug developer, to be honest, we're not really looking at those as useful ways to return value to our shareholders or even reach a lot of people. to be honest. I think they're more like technology projects at the moment. We're much more interested in actually those one and done therapies that could be delivered much more easily and at much greater scale. Just point to one example in our pipeline. We have a gene editor, a one and done gene editor in phase 1, we should go to phase 2 next year, that will permanently edit your PCSK9 protein down so that people will walk around with cholesterols of like 20 or 15 if you have this procedure once in your life. The cost to produce this isn't a lot. The cost to study it is huge. So we'll need to get it to a lot of people to compete with cholesterol medications. I think that'll be an interesting delivery system problem when that's available, but also a huge opportunity to arrest still the leading killer in our country, which is cardiovascular disease. So I think technology's new. The current systems aren't holding up very well, as far as I can tell. We need new models, like the partnership we formed with the Trump administration on the GLP-1 project that John might want to talk about. Maybe that's always been the case. Technology drives change, and we need to respond to that.
Great, thank you. David?
Yeah, sure. It's great to be with you. Dave, sorry you can't be with us. Congratulations on your anniversary.
Thank you.
I guess to be a reductionist economist, when I think of GLPs or CAR T as cellular therapies or gene editing, I see 3 different economic paradigms, all of which point to a similar problem. So GLPs obviously are pulling forward a payment stream for the drug that would offset some savings in cardiovascular status, inflammatory status, et cetera, at some point in the future. And, there are obviously evidence is gaining about what those look like and what the pull forward value of those would be. CAR T is actually quite similar. It's an adjunctive drug that sits on top of chemotherapy mostly. I think there's some for inflammatory, but it creates a more expensive course of therapy with a much better outcome. But again, the value pull forward is questionable in terms of the timing of it, and there's a lot of doubt about that. And then obviously the gene editing therapies as a once and done are actually capitalizing as a one-time cost what would have been a payment stream for a very long time. Again, sharing the question of what's the amortization value of that capital in terms of when it would accrue some real world value that would be equivalent to the value that was put out. And it's easy then to say all 3 of these are use cases where our payment system, which is based on a rent your health status model, are not prepared for I want to buy my health status kind of model. And there have been a lot of different proposals. These have circulated in the academic literature since I was probably a PhD student in terms of like amortization models or so-called Andy Lowe's mortgage models, but they've never left the lab and actually gone into anything approaching real world practice. And so to me, the question is, if we want to see these therapies shine, we have to make fundamental changes in reimbursement. And it's not value-based care. It has the same rent your health status model. And so, I think there's a lot of interesting discussion about what would that look like. But again, it's in the bottom line, it's a public economics problem because nobody would build a bridge across a river because there's too long of a benefit accruing to too many people. And this says the same thing. So the question is, what's the public structure by which we find a way to create these financing vehicles?
Great, thank you. And kind of leading then to John, as we're talking about implementing some new ideas or even where to begin that discussion. The administration, CMS, has worked to implement ongoing models that are trying to address some of these challenges, and especially the cell and gene therapy model, which from what we understand, many states are engaged with. And then also with balance, which is trying to think through kind of the drug pricing and lower drug cost. So what would you say is some early lessons learned, perhaps, as you're trying to put into some of these ideas into action? But also, is it kind of getting us to what David is envisioning, where we're trying to take these ideas out of the lab and into action?
Yeah, I mean, I think the place to start is to acknowledge that David's absolutely correct in terms of diagnosing what the system needs over time. We've had this challenge before. We used to not have a Part D drug benefit, and so we developed the Part D drug benefit folks like Dr. McClellan and others implemented it. And, the Part D program worked really well, but it is still based on this kind of rent your insurance model where it's an annual payment year to year. And an individual plan is not necessarily incentivized to make investments that pay off for beneficiaries several years in the future. So, we're kind of acutely aware of the kind of structural limitations there. And some of the programs that we've looked at are the cell and gene therapy model, where for sickle cell, we got around 80% of states to participate in the model and provide access to that therapy for patients. And in a large number of states. And I think that model, CMS negotiating on behalf of states and then inviting them to share in those discounts, is a model that can be replicable. And I think that for state Medicaid programs where the budgets are stretched, that may be a model, but it still leaves some of the financing challenges on the table as you think about new therapies coming to market. And so that fundamental challenge remains. In the GLP-1 context, we've explored the balance model, which has now been delayed in implementation until 2028. And there are kind of three dynamics that really led to that delay. One is, there's a lot of uncertainty around utilization right now. We saw a KFF survey that said 1 in 8 Americans are currently using a GLP-1 of one sort or another. Also, maybe reflected in the Lilly earnings announcements that were pretty positive a few weeks ago. We've got a Part D benefit that's still recovering from the implementation of IRA, where we've seen just a significant increase in costs and significant pressure on Part D plans. So Part D plans are in a particularly difficult moment in terms of accepting risk there. And so by delaying to 2028, we should get more data on which patients will be opting into that type of model and what those utilization assumptions will look like. And then the third piece is really just, mechanics within the Part D benefit in terms of enhanced plans versus basic plans, et cetera, that get very technical. But we think fundamentally that GLP-1 products can provide tremendous benefit to beneficiaries, and that we will see that return to the Medicare program. Writing all that up and putting it in a form that is satisfactory to our actuaries in a sustainable fashion remains a challenge in a year-to-year program under the model that David described. So we're optimistic, and we're using the tools at our disposal, but I think the fundamental structural challenge is there lurking in the background.
Patrick, so you've built your career, doing implementation of models at CMS, and now trying to address these challenges in the private sector. Where do you see a path forward for the integration of novel technologies into kind of established payment and care models, or do we need to be thinking about these differently?
Yeah, so a few thoughts. And one, on the public sector, I think you've seen a progression of models over time in value-based care and paying for value that I think are very positive. Certainly not every model works, but you have many of them that have worked. They've generally improved quality and experience. I think on total cost of care and affordability, which I'll come back to, some have clearly saved dollars. Many are sort of more on the margin, whether they save significant dollars. Then if you go to Optum, where we serve, 8 out of 10 health systems, 8 out of 10 payers, more than 8 out of 10 employers in some way. What we hear from our customers is primarily right now is the affordability issue. So they want the innovation, but they also want affordability. So I think our job as a collective public-private system is how do we deliver on that? Love what David said, and we've talked about this for a long time. Could you have longer cycles? Could insurance plans have longer cycles? By the way, a lot of our contracts have 3 to 5 year cycles for a reason, because we're investing for the long term in value-based care with our various partners. On GLP-1s, and applaud the innovation. We hear exactly what David said. Folks saying, "Well, I'm worried about the in-year investment. I'm worried about adherence. I'm worried about health outcomes over time." So we've tried to do that. We put them in a package of programs. So some of our packages around cardiometabolic, you'll see adherence rates that are 70+%, so significantly better. They can certainly include medication, and often do. Hemoglobin A1C rates that are about 2% better. Total cost of care rates that improve significantly. Hospitalization rates that go down on average about 18% in our value-based care models. So we really think it's a system of care around the patient. Some of you know I'm still a practicing physician. The story I tell that taught me the power and the unfortunate aspects of the cost of medicine. Early in my career, we discharged a child who had normal cellulitis. I was on the care team that did it. Child comes back in the emergency room, very sick. Luckily, the child did okay. And I asked the mom, like, what happened? She said, well, when I went to the counter, Dr. Conway, it was $200, and I didn't have $200. And so I was going around trying to find $200, and my kid got really sick. It's actually one of the many reasons at OptumRx, we now have 2 programs on affordability. I'll just name $0 to $5 copay on almost 300 medicines now, where there is no moral hazard. Think hypertension, cholesterol, diabetes. People, it's clearly evidence-based. They should be on their medicine. And then one I love called Specialty Savings IQ that uses AI, the internet, and looking for all programs, including from pharma, that support patients. And it saved people over $1 billion out of pocket last year. And then you take that to the personal level. I get an email from a gentleman, older gentleman, OptumRx serves him, and he says, you know, I was going on and off my cancer medicine because I couldn't afford it, didn't want to tell my wife. With this program, I'm now on it. I'm doing much better. Thank you. That's why you do the work. Later, hopefully, I'll be able to talk about some of the announcements we made from OptumRx yesterday, but it's all in the vein of affordable medicine that's part of a system of care for people.
That's great. So a question maybe back to Dave is kind of going back to the broader access and effective use of high volume chronic drugs. What do you think needs to be changed? And you were saying at the beginning that you know, the innovation in there, but we haven't yet reached a spot where they've become an integrated part. And so what else do you think needs to be changed as far as how these therapies are delivered and supported to kind of ease that barrier?
Well, if we're talking still about the obesity medications, and I appreciate what Patrick said there, you know, it's important to note, like, there are a lot of uses. There's no way, by the way, 1 in 8 Americans are currently using a GLP-1, unless KFF did their survey in Beverly Hills, and then that might be true. And I just say that to highlight the problem here in creating broad-based insurance products, you know, for the population. I'll give you a real example. So Lilly, you know, we have our own plan and we self-administer the formulary. And of course, we cover obesity medications at Lilly. And you can imagine there's like 100% awareness that Zepbound exists and it's really effective at getting your weight down. Interestingly, if you ask, well, what percent of the adults, we have 70,000 bennies who are adults, what percent are on Zepbound? Well, it's actually less than 15%. And that's after 2 years in the market at the manufacturer. Our out-of-pocket cost per month is $25 to the patient, and there's no deductible. So it's, you know, for our employees, virtually free because they make a good income. And that's the penetration rate. I find that interesting, actually, because people worry it's going to be like half of America. But that's the kind of the prevalent rate. There's people coming on, there's some going off. But the interesting thing for us is I think we have probably more adherence to label than other settings. People are aware of like the shortage existed, et cetera. And our current medical, total medical run rate costs right now, year to date, is minus 1%. Last year, it was 3%. The year before, it was 7%. So I think there's really only one thing that changed in our health plan, and that's that we had not massive adoption, but pretty good adoption of these drugs for people who are probably have high BMIs, were really at risk for prediabetes and diabetes, and we're seeing a lot of use. Probably persistence is better than 70% that you mentioned, Patrick, because it's so inexpensive to stay and people have good incomes. But I think it shows what's possible. On the other hand, I don't think anyone's talking about insuring people who have low BMIs, who have not tried diet and exercise regimes, have not done other interventions. And I think that's sort of the challenge with the current plumbing in a lot of our healthcare insurance products, is it's very hard to differentiate these things and people cut the corners, et cetera. We have worked with organizations like Optum and others to put different products in the market, different pricing packages, so there's more employee obligation. I think that's a useful thing to consider for lower risk kind of people. At the same time, how do we have things that if you have someone with a BMI of 40 and 3 comorbidities, that we actually call them and say, you need to be on this drug. And we're not there yet, but I think that's a world we can imagine, and we'd be excited to collaborate with people around. The final thing I'll say is, and you know, from a government pricing perspective and so forth in our industry, there's lots of kind of bank shot issues where if you do X, Y, Z happens that create disincentives to be creative from a manufacturer's perspective. And I'd love to see those removed where it matters. And this is a place where it could really matter. Those types of distortions also cause, other problems, I think, in healthcare. But putting that aside, they do get in the way of innovation. So, for instance, I just said, like, we've had, I think, full awareness and 15% of our employees are using the drugs. If people are worried about budget certainty, that's something we could do. We could just say, well, if you have more people on these drugs than Lilly does, we'll just cover that, or we'll just cap your costs. I think that would really solve a lot of employer problems. But it's very, very difficult to imagine implementing that under the current kind of government price constructs, which require us to give Medicaid and other entities pricing, and we can't do that into an unknown. So that's an area to work on, and maybe an area to pilot as well, where you can carve out one or two things where it might really matter and say, let's flex here, see what happens. If there's abuse or other problems, fine. But if it actually expands coverage and improves the health of America, that'd be a useful thing we'd be interested in.
Yeah, we're going to have a discussion later with kind of thinking for employers, but did just want to see if there is any kind of reaction from the other panelists to Dave's ideas, and especially if it meant like a piloting approach.
Well, I mean, I think we've had substantial discussions with Dave about pilot approaches, and they've been incredibly productive conversations. I will say just a credit to Dave and the Lilly team. They've been incredible partners at every step of the conversation around GLP-1s. And I think a lot of patients, and we've seen utilization data on this, a lot of patients have been able to access those products on a cash basis through the Trump RX pricing regimen there. And I think that's been tremendously productive. Obviously, we still have some conversations to go through on the government side in terms of identifying the pricing structure, working through some of the distortions that Dave described, and some of the disincentives in the system that make these pricing dynamics particularly difficult. So I think that there's just an incredible amount of opportunity in the GLP-1 space. I think a lot of folks are still waiting to get a fuller picture of all of the side effects too, as we have a number of these products launching and some exciting developments over the next 6 to 12 months. And we've had orals from the two major companies in that space launched just this year. So I think that there's a lot of data we're still gathering about these products too. But hopefully over the next 3 to 5 years, both on the government side as well as on the commercial side, the value proposition will be so clear that everybody will be willing to make that investment and pull these products through. And that's certainly something that we're very energized about, and have appreciated collaboration with Dave and others in the industry on as we work to make sure Medicare beneficiaries have access, and hopefully in the future work towards Medicaid also.
Yeah, likewise, John.
And maybe just building, and certainly we've had a strong partnership with Dave and Lilly as well. On the public sector, as John said, and I used to work there, I think thinking about the rules and sort of parameters that both barriers that can be removed and incentives is directly on target. What I'll say in the private sector, I led our CEO of Optum Rx for a few years. We announced something yesterday. It's a culmination of work over multiple years that will continue to evolve. But there are many incentives in the system that you tackled through transparency, affordability, and choice. So number one, we announced early 25, 100% commercial rebate pass-through. Not sometimes, not in some offerings, all the time, all drugs, et cetera. We announced yesterday we would take that a step further and say auditable all the way back to the GPO, so the group purchasing organization where there's been a lot of rhetoric around. We also announced, and Dave, you may not have seen this, we can send it to you. We want no earnings tied to list price. So there's this lingering doubt of like, PBMs and pharmacies will make money off higher list prices. We want to remove that lingering doubt forever. So we said we're not going to have earnings from any of our products and services tied to list price. Very differentiated. By the way, Buddy Carter, we were talking about this, tweeted something positive about Optum Rx. Buddy Carter.
Wow.
That's saying something. And like community and independent pharmacists are like, we love Optum Rx. I was like, I didn't see that day coming. But we did cost-based reimbursement, not like some public figures for some drugs where you can make money. For all drugs, all pharmacies, 100% of independent community pharmacists, Buddy Carter and pharmacists like that as well. So now let me tell you what happened in the market, which we hit on in my interviews yesterday, but didn't get written about a lot. We're actually growing faster than the other entity in market by more than 5x. So why is that? It's because guess what? Your customer, when you offer them a transparent, clear set of products and services, actually buys your product. So we added record numbers of clients for 3 years. We've had retention that is almost 100%. I've almost never been in a business where you have retention at essentially 100%. And I think it's because you actually modified the model ahead of regulation and you met your customer need. That actually is good. I mean, Dave, you should comment. I think that's good for Eli Lilly and every pharmaceutical company because it means there's a transparent, clear model. But Dave, you should feel free to comment.
No, congrats. I hadn't heard that, and that's great news. I think it does remove an uncertainty whether it was true or not, and I think that's good. And it's consistent with the, the Trump RX idea, which is like, why do we have such different prices depending on who you are? I think it's kind of a crazy place we've evolved to. We don't need it, especially we're talking about high volume products that are quite useful. Our biggest problem is not pricing of GLP-1s. Our biggest problem is access. And the tools we're using to solve that aren't good enough because we still have half of America without access. So I think that's, applaud that, and that's a good step forward. And hopefully we can make more progress on some of these other creative ideas.
So I want to take that kind of theme of access and look at it in our kind of and beyond section of this panel. We've talked about the chronic high volume drugs, but we are seeing, and we've heard quite a bit today about the discovery that's ahead of us, the types of scientific possibilities around cell and gene therapies. What we've seen on the market, though, perhaps have not been kind of immediate uptake. And so we've heard different reasons for why that would be. I'd love to get a perspective here, price or non-price. What do you think are some of the barriers to the access, the availability, the use of these types of novel technologies that are so different than our kind of chronic model?
Sure. Well, look, Dave's already talked about the dynamics of access with GLPs. I would just say I'm not particularly worried about GLP adoption. I know it's easy for me to say. I don't have to face Dave's shareholders. But I say that because it looks to me like the market's working. We've seen significant price competition. We've seen many new follow-on compounds coming through. There's a robust pipeline. That tells me that the market's going to equilibrate at some point where the value is realized in the price, and there's going to be, at least price as a barrier to adoption will be, if not removed, at least become a marginal factor. Maybe a few years. But CAR-T, I'm actually not worried there either, and I'll tell you why. It is low adoption. Like the number of people that have indications for CAR-T that actually get it is sub 10%. But the two reasons why people don't get the therapy when indicated are they won't travel to one of the very few medical centers that are still qualified to give it. And so expansion of those competencies, which are quite complex, are necessary and happening. And secondly, people die during the evaluation process because they are suffering from advanced, quite significant illness. And that's a function of, I think, the former, how long it takes to get it approved, how long it takes to get someone there. The reason I'm not particularly concerned about the price aspect is if you look at, for example, significant innovations in so-called bedside CAR-T, which are, many fabs that can create the compound in a week or less, at least theoretically. And then things like mRNA editing of the chimera, which allows the cytokine storm to either be bypassed or not happen, which is a significant cost add. It's a month in the ICU and it's quite advanced therapy. I see us normalizing that. And I think CAR-T in a lot of areas will be considered a standard of care quite soon. The area that I'm really worried about, cell and gene therapy, less than 1% of those who have indications get the drug in the United States. There are 35 compounds on the market. There are about 150 in trials right now. And all of them have the same phenomenon other than sickle. And I applaud what we've done in Medicaid as a demonstration, which is they are prohibitively expensive. And despite the talk about platform therapies where the second drug on a certain rig could be a lot cheaper, that's not actually happened in any trials yet. And partially it's FDA, but partially the science. I hope Jennifer's not in here because I'm going to embarrass myself, but the science is just not ready for that yet. And so that to me is an enormous public policy problem that has a huge blowback into the investor community. So Dave, with his balance sheet and investment capacity, can withstand those investments based on the belief they'll come through. If I'm a small 1 or 2 drug company, I can't do it at all. And my investors have started to bail on this idea that these gene therapies will get, this adoption. And so we're now facing this. FDA approval used to mean you get access to the market. Now it means you get access to the question of, do you get access to the market, which is a financing question. And so I don't sit here and propose an answer because, we could create a select risk fund. That's kind of indirectly what you're doing. We've done that in other areas of healthcare where we have access problems. That would work if we're talking about once and done therapies for 1 in 10,000 type treatments. But if Dave's going to come through with his cholesterol drug, or we're going to do, an Alzheimer's drug where they are broad access, those risk pools would blow up within years. And so this is something that requires, I think, a lot more thought about how do we structure this capital finance around these drugs. And I hope we really lean into it, because that will unlock, I think, an enormously promising future.
Well, you say this is an opportunity for public policy. So as we're trying to think, even those in this room or the work that we're doing at Margolis, is it to focus in on one aspect, whether it's this platform capabilities in the manufacturing? We hear a lot about regulatory uncertainties, but then at the end of the day, it does often come back to the discussion around pricing and payment. Where would you suggest that we put our efforts, or is it going to be all of the above in order to make any progress?
I mean, my view is if you look at the 35 compounds that are out now, 32 are aimed at children or babies. And so, you're sitting in the key seat. And so, a children's solution, let's be honest, where the amortization value is enormous. We're talking 70 years of amortized value that we've never seen before. That feels public policy financing to me. I just don't see how we would plug that into the rest. But a number of compounds are coming down that are targeting working age or early retirement age. And I think we could construct a mechanism by which insurers could buy into a risk pool. Could be publicly backed. It doesn't have to be. I think there's plenty of capital in the markets, and that amortization could happen. So if I have a patient in my plan and it moves to Patrick's, then his amortization schedule picks up the amortization schedule. It doesn't require government perhaps government benevolence, but I think it depends on who is the target population and what are the dynamics of care financing around those populations. I don't think we're going to see a one size fits all here.
Yeah, maybe I'll add on to that.
You'll take over my patient?
No, it's sure.
You just said no.
No, I will. I'm happy to take.
Okay, good.
We love to take all the
I have to be as
all the
close
risks.
as- yeah.
No problem. Look, building on that, I do think there's a set of that Margolis and others have written about. There's a set of public-private partnership financing mechanisms, some of which have been tried, that I think you could do. We in the private sector have reinsurance and other products that solve part of the problem, but they don't solve the whole problem.
Right.
They're helping an employer or others through the challenge. To bring this back to the clinical again, I finished at Boston Children's for residency. I start my first week at Children's Hospital of Philadelphia. I told this part of the story that I'm going to tell the second part of. Get a child who's bounced around America for 2 years, about a 1,000-page chart. On page 487, after many hours, I realized it's a rare disease, which ended up being correct. I tell it in AI on diagnosis that child in the future should be diagnosed anywhere in America, by the way, anywhere in the world, within minutes. That creates much better access. Then we have to figure out the access points to both in the US and the world to get the various therapies to them. We got to figure out the price. But I took care of, if you have delivered to a family a diagnosis that means death to their child, which I have done many times, there is nothing worse. And I now have seen kids that companies like Dave and others have created therapies that cured them. That is amazing. We do have to figure out the public-private financing mechanism of that and how we create those accessible therapies. I took care of a sickle cell kid a few months ago who had no idea, zero, his or his family, of the various options available to him. That is a teenager. That is a major, major problem. And so, between public-private sector, we have to figure out how to tackle this because it's a equity issue, it's a health outcomes issue, it's an access issue that is going to get more and more prevalent and more of an issue as the pipeline expands.
Great points. This has been a great discussion. I think I want to end with, David started us out saying, we've all have to be working on this together, and that we've been doing, action forward in different parts, but it's still a lot to do to move it ahead. And so I would like your idea, one idea that we could take on in the next 1 to 2 years that would get us onto a better trajectory of incorporating these types of novel, disruptive, potentially very powerful therapies into models of care.
Dave Ricks is CEO of the most highly valued healthcare company in the history of the world. So we should go to him
Okay,
first.
Dave. On that note.
I'll answer that. I mean, our main job is to make the drugs that change the thing. And just on this one and done idea, I am super bullish that things we take as a pill every day that work okay, we'll be able to have one and done interventions that will change our lives with one intervention. And unlike the things that David was describing, which have intensive like hospitalization costs wrap around them. I mean, CAR T is amazing. Sickle cell ex vivo therapy is amazing, but it's a little bit of a proof of concept in a way because it's very difficult to scale in the US, let alone on the planet. But those will be solved, I think. And then the question will be like, who bears the costs in return and where do the savings accrue? That's a lot easier than making the technology to begin with, I think. It's conceptually easier. We have to fight the varied interests and the complexity of what we inherited, which is hard. But we're up for it and look forward to partnering with all these folks here and others to do it. I think the one big idea is to free up more agency for consumers. I think what we learn in like this obesity GLP-1 thing is that well, it's really not that hard to conceptualize a high-risk group and we could do an intervention like we do medical. Prevention is something a lot of people want. And what's different about those therapies is you not only theoretically get prevention, like if you take a statin 10 years before you had your first heart attack, but people feel like they're preventing things because they look different and feel different within a few months of starting the therapy. Certainly, consumers should have some skin in that game, but they also are very interested in that game. And I think probably it's a good time to think about policy responses that pull consumer interests, and maybe this gets into funding HSAs at a higher level and having more decision-making delegated down. But I feel like that will be more successful than top-down strategies we come up with.
Okay, thank you. Patrick?
Yeah, it's interesting. I'll go back to the people we interact with. So employers, health plans, others, et cetera. What they're describing and dealing with is a crisis of affordability, health outcomes that are uneven, and experience that's uneven across our system. I actually think, and we'll see what John says about this too. I think United Health Group and Optum, our mission is to help people live healthier lives, help the health system make work better for everyone. The beauty of the seat that I get to sit in with our team is you actually have the capabilities, the assets, the people, and the scale that can be used for good. So you can solve people's physical, mental, social, pharmacy, financial needs across the whole system. Scale often gets spun as, well, scale or big is negative, and I understand why that happens to a large degree. I don't, as much as, and this isn't what Dave said, but sometimes people say, oh, if I just invent the medicine, magic will happen. Or I'd love for that to be true, but I don't think it's the reality we live in. And so I do think we have to have a system that's public and private, and I'll let John comment at the public, I don't do that anymore, that actually solves across that whole system. And to do that, you actually can't have niche or singular solutions. You've got to solve for populations and individuals on longer time frames. And I think that takes a much different sort of viewpoint and approach and organizational approach where we will need both the public and the private sector.
And he had just kind of laid that right up to you, John. We'll turn to you next for your idea.
Yeah, I mean, I think that's exactly right. I think when we look at the challenge here, the challenge is different for the different populations, as David and others laid out. Medicaid and the CHIP population is a completely different situation for curative therapies than the adult population or the near retiree population. And so I think in terms of public policy from a CMS perspective, what that means is that we need models that are well suited to these problems. And the nice thing is that if you identify that at the population level and you have the scale to implement and work with states, once people get comfortable with that framework and once the financing is there and it works, you've got a sustainable model going forward. So I think we can build on the sickle cell approach, hopefully for other therapies but separately for other populations, including the population and access around GLP-1s. We need to identify new solutions because our current system just isn't set up well for that. And so the Medicare population, obviously, we have kind of a bespoke solution that we're working towards. But I do think we need to identify these, and then we need to surface those and partner with folks on the Hill and elsewhere to figure out how to get those into law. Because again, I mean, it took a long time, but the Part D benefit passed, it was implemented. And we are where we are today with it, which is, tremendous access at a fairly low cost point overall for beneficiaries. We can solve these problems. We've done it before, but we need to describe the problem correctly in order to tailor the solutions. And I think we're doing that.
Thank you. All right, Dave?
Well, I guess I'll say what we should do is something I tried to do for a few years and failed miserably. So I'm just going to ask if we all try it again. There are 50 companies, private insurers, that if they came together and created an exchange mechanism to be able to share and amortize cost of gene therapies, it would not eliminate the problem. It would eliminate a very large share of the shock cost problem. And that basically is an agreement with some government blessing, because it could be construed negatively in the wrong way, that if I'm treating a patient and then they transfer to your plan, that here's the amortization schedule and you're going to pick it up. It's been implemented in other industry sectors where there are long-term infrastructure problems, and I think it's very doable, and it's not a very large number of companies to do it. If government was involved too, it could be even more expansive. I view this as a structural problem that has a structural remedy, not a financing problem. So I just hope we can keep that up front.
Thank you, and thank my panel.
Okay, is this on?
No time like the present.
I think I'm. Okay, excellent. Thank you for that amazing session, and welcome to our session on employer-sponsored health insurance. I'm Kate Bundorf. I am a professor of health policy and management at Duke University and a core faculty member at the Margolis Institute for Health Policy. So we heard in the preceding sessions about some incredible promise for technologies to transform healthcare treatments and care delivery. We also heard about many barriers to implementing these new approaches, particularly in the context of our publicly funded healthcare programs. In this session, we're basically going to take up Meena Seshamani's call to action on what are employers doing and what is their role. Employers are important in this question. They direct over $1 trillion in healthcare spending through their benefit decisions. So they're positioned as important drivers of transformation, yet they face very important headwinds. Kaiser, the KFF reports that premiums for family coverage have increased by 6% or more over the last 3 years. This is an important affordability issue that we've talked about already. In the context of employer-sponsored health insurance, the affordability issue is primarily in the form of wages that are growing less slowly than they otherwise would for employees, the role of contributions for employer-sponsored insurance, and high cost sharing for covered services. At the same time, many employers are leading the implementation of very innovative programs with the goal of transforming care. And in this session, we're going to explore these trade-offs. Okay, so I am thrilled to be joined here by my distinguished panelists. We have Dan Mendelsohn. Dan leads Morgan Health, a business unit at JP Morgan Chase focused on accelerating the delivery of new care models that improve the quality, affordability, and equity of employer-sponsored healthcare. Previously, he founded and led Avalier Health, and before that, he was in the Office of Management and Budget in the Clinton White House. I will also note that Dan has some deep Duke connections. He was there in the very early days of our health sector management program at Fuqua in the School of Business and taught a course for many years for our MBAs. Cheryl Pegas is chair and CEO at Flight Health, and she serves on the boards of Boston Scientific, Concentra, and the American Heart Association. And she's also an investor in private companies focused on team-based care, cardiology innovation, and healthcare simplification. She has previously served as a partner at Morgan Health and the executive vice president of health and wellness at Walmart, right? So they've told me that this is going to be a very energetic session with those prior connections here. One thing I will mention is she is the co-chair of the Duke-Margolis Capital Impact Council, so often also has very deep connections to Duke-Margolis, and we'll talk a little bit more about the Capital Impact Council as we go along. Okay, so let's kick it off by thinking about employers as purchasers. Employers have been purchasers of health insurance for over 50 years, so nothing really new here. What makes you optimistic now about the role of employers in driving healthcare transformation? I'm going to start with Cheryl because she's right here on my left.
Great to be with everyone, and also great to be with Dan. We've done some of these before. So we'll see where we go, because I think lots has changed for employers. So what I would say is employers used to be really, really interested just in their annual premium cost, and they would focus on what is happening there.
Oh, yeah.
You're back.
Hello.
So I was saying, there's a lot that employers have done, I'd say in the last couple of years. In the early days, employers just focused on their annual premium cost. No real understanding of what populations in their employee groups were causing a rise in cost. Not really understanding, I think, some of the negotiations, frankly, with their insurer. That has changed dramatically because this cost is now a line item for their CFO. It's not just in the pocket of a benefits leader. Mm-hmm. And so they're really looking at, how do I bend the cost curve completely? How do I manage total cost of care? And I think that the reason that's really important is that annually, even if you think you're investing in your employees' health for that year, you can see an improvement even in 1 year. And I just really want to highlight that, because we talk a lot about this is a multi-year ROI. You can see changes in 1 year. Are you structured to get that data at baseline? Are you able to look at it at the end of the year? And can you negotiate cogently with your insurer for your annual premiums?
Agree completely, and I'll add a couple of things. First, I'm not sure what's happening with Dave Rick's health insurance premiums, but ours went up by 10% last year, and part of it is technology. I mean, the GLP-1s have come out. It's a driving trend for us and for every other employer in the market. With the emergence of the cell and gene therapies, CAR-T and the like, there's been a lot of discussion about that, to date. And I love the fact that we had like a sitting member of the House of Representatives talking about that this morning, because we have to be thinking about making a market for those technologies. It's going to change everything. So that's kind of another aspect of it. So technology, I think, is changing a lot. And then data is the other piece. So employers now, because of data, have a much more granular understanding of what's actually happening in the populations. And if you are a fiduciary for a plan, you have an obligation to go in and really start to look at what's going on. And when you look, you see that there are certain geographies where people cannot get care, where there are very high level of chronic illness that needs to be addressed. And you have to take much more proactive role in doing that. And then I would say kind of the last thing is that there are now technologies that we see, and many that we're investing in right now to help accelerate their progress, that are using AI to help drive a better consumer experience. And so, the standard benefit design is very antiquated, and employees are really starting to expect a more bespoke digital experience to help guide them towards high quality, lower cost care. And that's really, I think, what has changed since the last time employers started looking at this.
Great. So I heard a consensus on rising costs and the important role of access to new therapies, but some challenges around there, the potential to do it in kind of year after year or within the year, and also the important role of data, right, that we've talked about before. Dan, you talked a little bit about a potential for AI to really transform the employee experience and accessing care. Let's step back and think about what models or innovations do you think are most important, right? Yeah.
So I'd say that in the prior panels we're discussing this, the idea of clinical pathways and really deploying clinical pathways. I think there's tremendous potential there, and so we have one portfolio company, Time Care in oncology. And what they do is they deploy AI to help employees who have been diagnosed with cancer to find a better experience, lower cost experience, high quality experience. A lot of it, by the way, is helping employees understand that they can get really high quality care in community oncology less expensively than going back to the same academic medical center where they might have been diagnosed. And so, there's kind of an element there that I think is important. I will also say, though, that we do see upcoding coming in from hospitals, and that is driving trend as well. And so, there's kind of a put and a take against AI right now. And I see it as really our role to help accelerate the more clinical aspects of AI so that they can come to market and that can ultimately achieve these objectives that we've laid out for ourselves.
Is there anything we can do about the downsides, thinking about the upcoding and the risks?
I think that it's a very important question. We rely on our insurers to be thinking carefully about that, and that's a very important role. And there's a little bit of an arms race going on, let's be real, where you have upcoding that's happening from the provider level, and the plans ultimately have to be the ones to help us with that.
Great. Cheryl, what is on your mind in terms of the most promising opportunities in this employer-sponsored space?
We started out talking about cost, and I think cost drives all of the ways, frankly, we think in healthcare. I'd say this past year, employers really got hit with specialty pharmacy cost, and then this rise in cardiometabolic conditions, and really changed, I think, how they began to look at this. And just so I just repeat that, it's the cost that drove them to focus on this. Maternity cost, you hear everyone talk about the high cost of maternity. I'll just mention to everyone, coming back to, do we really understand clinically what drives cost? I don't know if everyone knows this, but the number one cause of pregnancy-related cost is also cardiovascular disease. People forget it. So when you think of, hey, I'm an employer and I'm managing 18 to 64-year-olds, 30% of your 20 to 30-year-olds have obesity and prediabetes already. That's what you're managing. And so if you don't know that, you're not putting in any solutions to help manage that. Throw a new treatment on that's kind of being spread around to everyone. An employer has to start, I think, looking at who can help me manage the overall trending cost and also provide appropriate care. And I'll just say this, self-insured employers, large employers, have a lot of control in what they can do. You don't always see that happen. We've seen, I'd say about 79% of employers still use a broker. The types of data that they can get back to help them plan on an annualized basis is just not being taken advantage of. And so if you know where your costs are going, and there's a new treatment like GLP-1s, to the point that I think even David Ricks made, not everyone should get those. People who are lower risk probably shouldn't. It should be your highest risk population. And if you focused that in getting it just to the highest risk population, your overall spend on pharmacy is lower because you're also decreasing your medical costs. Do you know how to choose a partner to do that? I think those are the things that employers need help with, that benefits teams need help with. The last thing that I would say, as we look at this, because there is innovation in how do you look at new pharmacy solutions? Didn't come up today a lot. I was going to actually, if Dave Ricks was still on, I was going to say, those are the models. So they introduced a B2B model directly to employers. They said, hey, we'll go straight from manufacturer to employers. And we want to make sure that clinicians do the right thing. And so we'll make sure that people who are following evidence-based guidelines for managing cardiometabolic conditions, they're the ones we're going to partner with. If every payer could do that, we would change care. And I'll just say one thing. I'm a physician, obviously. It's not the cost of drug. I just really want to make sure that everyone hears that, because I think Patrick brought it up as well. We have generic drugs in this country for hypertension. Pretty common condition. 80% of people with hypertension see a doctor. It is not an access to a clinician issue. For all of you who are clinicians in the audience, only 23% of patients are controlled. It is truly, how do we get better quality care for people who are already in the system with low cost medications or interventions? So for those who actually need higher cost interventions, our clinical care model enables it. It's a focus that we don't spend enough time talking about. It's where pay for performance and different purchasing models have come about. It is a low-hanging fruit in the model, be it Medicaid, Medicare, or commercial.
Excellent. Okay, so I heard Dan talk about the potential for data, right? We have all sorts of new data sources, and we can dig in deeper than we ever have been able to before for employers. I heard you, Cheryl, talk about, yes, potential for data and really not being utilized, right? So we could do a lot with this going forward. And then I also heard you talk a little bit about, employers might be different, right? Large employers might, use that to think about interventions specific to their population and the type of care that their patients need. Let's switch a little to think about evidence, right? Like, how does an employer know what to do, right, with their particular population? I know that evidence is something that you've worked on a lot, Cheryl. I will point the audience to Flight Health's website, where right on the landing page in the middle, you can see the studies that Flight Health has done, looking at the impact of their innovations. What kind of motivated you to do this in partnership with the large self-insured employer, I believe, and how has that affected your work on the Capital Impact Council?
Yeah, it's a little bit of what I was just talking about, using hypertension as an example. We lack a lot of real world evidence. People talk about GLP-1s and say, oh, we don't know the side effects, or we haven't seen it long enough. What they're really saying is we've seen very controlled trials to bring a product to market through the FDA. But what happens when it's just people in the wild? What do we see with that? The other thing that you want to test is, will clinicians follow evidence-based guidelines, coming back to evidence, because evidence is not just results. It's, are the guidelines being utilized appropriately? In 2023, the American Heart Association coined the term cardiokidney metabolic. And the reason that was coined is because of the rise in, obviously, pre-diabetes, obesity, but really that it led to cardiac and to kidney disease. And what we're really trying to understand when we think of the overall total cost of care across the American healthcare system is, where do you intervene the earliest? And the only people who intervene are clinicians. And so we wanted to see, could you take an AI algorithm for treatment, run individual patient data through it, and spit out a care plan, and then commit your clinicians to following that care plan? And if they did, could you achieve a couple of things? Could you achieve scale? Could you ensure the right people got the right treatment? And could you, on top of that, impact cost? And, if you'd looked at all of the clinical studies that Lilly and Novo did, it's possible. But Milliman independently analyzed it, and you are able to achieve it. And so what we saw, and again, this is real world evidence, not a clinical trial. It is why it is on Milliman's website. We saw an 86% adherence to treatment, unheard of for any treatment. And that is because the incentives were aligned. The patients knew what they were getting. And if they didn't get a GLP-1, they trusted that their clinicians were knowledgeable enough to not give them a GLP-1. And if you got a GLP-1, you were so tracked, not by a doc, but like a community health worker who would find out, can you afford this? Do you need it delivered? Do you have a way to measure things at home? The types of questions that you should ask patients to help them be successful. For our clinicians, Dan mentioned AI, and I think Bob did Wachter in an earlier session. I cannot overemphasize the importance of AI for clinicians to be able to easily cull and do the right thing in that 15, 20 minutes that they have. So we use ambient AI. We pull everything through, and we've achieved great results with significant cost savings, about $100 PMPM per month. I mean, just really significant cost savings. But we've also seen, huge drops in hemoglobin A1C, LDL. And so this is my way of proving to myself that with evidence-based care, really good use of technology, patients can do really well. And we can and should scale that. And so that's what we're really focused on. But employers need to know it's available to them, because I think there's this fear of asking the question, well, will it work? Will people know how to do it? Ask for it. Take in people who can do it. And, just to give credit to Dan, those are the types of companies that he's trying to invest in to bring to employers.
Excellent. So let's turn to Dan. Tell us how you're feeling about evidence and we're trying to encourage the development of evidence. And can I ask, let me ask one more thing. So in an earlier session, we talked about, well, if the program works in one state, how do I know it works in the other states? If a program works in one employer, how do I know it works somewhere else?
Evidence is critically important. We have 13 portfolio companies, and we also have about a dozen active pilots in our environment. So if you think about our environment, we're taking these minority positions in innovative young companies, and then we're also testing technologies and approaches within the JP Chase benefit. And we've created a very robust data environment through which we can test and learn. And that's really kind of foundational to what we're doing. I'd say that in some cases, our portfolio companies have RCTs. And that's what we like to see. If a company has a randomized controlled trial and they're saving money and reducing costs, that's great. Not all companies have that. And so then we move into kind of more experienced data, and we will not invest in a company that doesn't have some data, or at the very least, a mechanism through which they can start to calculate what their effect is as they progress their technologies. And then when stuff doesn't work, we terminate the pilots, and we've terminated now 3 out of 12. And so that just kind of shows you that like we will be responsive to data. I'd say that some of the claims that we see are overstated by companies that come in. That's natural. It's to be expected. These companies are trying to sell their stuff. I don't think they're misrepresenting so much as they are representing the positive of what they see. So it's something that I think as investors and as kind of students of this stuff, we have to be skeptical when we see claims. And that's something that I think benefits managers are very highly attuned to. At the same time, they can't decide that they're not going to look. And I think that kind of to Cheryl's point about having some level of confidence and trust that better is possible, we have to get there. We meet a lot of skepticism from benefits managers. And especially in this world where things are changing so fast with AI and with technology and with approaches to things and like the improvement in the data environment, there needs to be a psychological shift among the benefits managers and they have to embrace the idea that better is possible.
And how about this idea of if it works once, do we try again? And do we test it? Do we change it?
Look, I mean, it really kind of depends on the nature of the evidence that we're putting out there. We have a great advanced primary care clinic in Ohio that we're running, and we're seeing really excellent results. There's no reason to think that won't scale into other environments where there are, strong primary care assets that are put in place in a similar way. I want to just maybe, this is a little bit of a digression, but we've been talking about benefits managers really as if they are the benefits managers of the Fortune 100 companies, which is, kind of one perspective, but about half of the employer-sponsored healthcare, think about 180 million people in this country getting their insurance from their employer. About half of those are small businesses and medium-sized businesses. And these businesses do not have the level of knowledge, understanding, or control over the benefits environment that they face. And so, like in our environment, Chase serves about 7 million small businesses in the United States, and we hear from them, and they are struggling with these cost increases because they don't have the capacity to absorb them. And then they also do not have the data and the infrastructure. And I think that, if we're talking about policy solutions, addressing the issues of America's small business is critically important to starting to address the employer sector.
Yeah, so that's a great pivot, and I think small employers are obviously very important and have borne the costs, have fewer mechanisms to address the costs in the way that the large self-insured employers do. And it seems like small employers, they kind of have two problems here. They have to think about how to manage their benefits, and they also have a lot of issues around buying insurance and choosing different health plans. Let's go back to our where is the potential question? Do either of you see, what do you see on the market for either on the market or in the policy space for helping small employers with these issues?
And I'll kick off and then turn it to Dan. Pooled purchasing matters and can work. I mentioned this access to brokers before. Being able to have someone who can come in and pool a group of employers is really important. There's a company in the audience, Traveris, who does that for small employers, and they do it around their pharmacy benefits. So knowing that the solutions exist to do that is really important, because I think sometimes people feel they're out there by themselves and they're not kind of integrating themselves into these existing groups. It requires a little bit of work, but AI has made that work a lot easier. You truly could do a lot of great research about what are the pooled groups for purchasing within your geographic area. How do HIEs work in your geographic area? What are the new innovative pharmacy solutions? Everyone's kind of tiptoeing around that. Those are coming fast. It is why PBMs are changing. It is a huge opportunity for small employers. And so I think that knowledge, and where do you get that knowledge to be able to do that, is really the gap that might exist. AI fills some of it, but what are the forums that get you here? And then you are able to do some things with that. Again, if you're able to get pooled data, easily run an algorithm through your high cost, tends to be the same things. Dave Ricks mentioned it. It's always cardiovascular. It's always maternity. It's always oncology. It's not going to be that much different. What you really have to then figure out as a small employer is, what's my access locally? And the access is the real, all day long. And this hybrid model of virtual in-person care is how you address that, not just as a small employer, but as a rural employer, et cetera. And we're not bringing those forward enough. A little bit is the skepticism of, I think, benefits teams, but a lot of it is making sure that those who can and those who write guidelines are shouting that from the rooftop. Here is how you do it. Here's what has worked. Here is what has scaled. because there are a number of those solutions.
Yeah, so we hear a lot about trying to promote more sharing of information across state Medicaid programs. We could think about the same types of things as well across small employers.
Absolutely. I mean, I'll just give a plug for some of the work that we do at the Capital Impact Council. It is a group, Mark McClellan and I, one weekend when, and if you guys know, Mark doesn't get a lot of sleep, but on weekends when he calls you, it's always late. It's like, what if you listen to the what if? I, by the way, I'm on the West Coast, he's on the East Coast. I benefit much more from the late calls than he does. But it really was, how do we take solutions that exist and bring them to populations where local communities can't invest, right? A health system in a community can't really invest in a cardio-kidney metabolic solution. They're trying to just keep the doors open for emergency procedures. The people who invest in those are private investors. They bring innovative solutions to markets that cannot do them by themselves. Private investment, however, has received lots of negative marks. And that is because they're not measuring what we're talking about. How do you measure the value, the health value that you bring? Not just the financial value for you and your shareholders. How do you measure health value? And so we formed a group, Capital Impact Council, to do that. And one of our requirements is that every solution that's brought to market has to almost have an analytic component that shows that you improved clinical outcomes, you improved access, you lowered cost, and you can't become a member without doing that. And you've got to publicly put it out there and hopefully influence how you go forward and partner in investments. A lot of this is available on our Capital Impact Council roadmap, but it's our way, I think, of saying this is a big elephant, one bite at a time. So first, let's get right solutions in market. Let's get that data. Let's make sure that as we invest, we're investing in those right solutions. And then how do we then make sure that payers and employers come along? And Caroline's here. We've got a partnership with Peterson and we work with Milliman. It's all about the data, but it's all about real world evidence, not what you just see in very, very encapsulated areas. And what we see in real world evidence is that it's possible. To Dan's point about skepticism, which will probably be the word that sticks with me the rest of the day. These things are not only possible, we should be doing them. And leaders who are looking at benefits or looking at cost, who really are looking at population health community by community, we should not only ask them, we should give them, we should ensure that it happens and then follow through on that. And so we're committed. A lot of you in this room are committed. It happens when you're leaning in.
Okay, I will say thank you for answering Mark McClellan's call at whatever late hour that was. Right?
That was 2024.
Okay. So I hear a lot about kind of bringing capital forward and deploying it in ways that promote value and creating the evidence that these interventions are generating value and sharing lessons across different employers. There are other policy mechanisms out there. I'm specifically thinking of ICRA, right? And thinking about that's a very different approach to thinking about small employers. Basically, kind of having the small employer have a budget, right? And then, enabling them to provide the tax favored status to their employees, but to go out and get kind of their own health insurance. Thoughts?
Yeah. So
I could tell you had thoughts there.
Yeah. So this question about for small businesses, what are the options, which is the question that you ask. And I think, Cheryl talked a little bit about group purchasing, which is important to look at. A number of other tools that are available to small businesses. And again, let's start with the fact that most small businesses do not have the time and the energy and the interest in really delving into this stuff and spending a lot of time on it. And so that's kind of the place that we start. ICHRA is a solution. And in a market where there is a strong health insurance exchange, ICHRA can be a very valuable way. It can be less expensive. It can be, but you have to look at it carefully, because the fact is that, especially given the instability with some of the health insurance exchanges as a result of the expiration of the subsidies, it's not been as stable as many of us would like to see, and so you kind of take that for what it is. And I think it is a place where we have an opportunity to build on it. Another option are narrow network plans. And, when you think about where narrow network plans were 20 years ago, very different today, with the benefit of technology and with the benefit of kind of better information coming to consumers on a real-time basis. We have one really interesting small portfolio company called Centivo. And what they do is they go in and they contract with a leading health system in a specific geography. So we offer to our employees in Dallas a Baylor network. And if you're ready to accept Baylor for all of your care, you can save about 20% on your cost. And we pass that cost on to our employees. And so, for a small business that is contracting for health insurance, if they're ready to accept that narrow network, if it is a very high quality network, that is an option. So we have narrow network plans, we have ICHRA, we have group purchasing. And then, there are a range of other places where I think policymakers can engage. And we're working with Mark and with others. And, Caroline is also kind of very actively engaged in a lot of these discussions as well. But we have to find and nurture better options for small business if we expect to see them stay in the market.
Okay, amazing. Okay, so we are running to the end of our time. Can we do a quick hit? We're trying to promote innovation among employers, small or large. What is your number one policy wish?
Payment models that allow them to invest more than annually. And that, I've thought, what are the incentives? I sometimes think of them as prevention incentives. What can we do from a policy perspective to make employers look at that differently? Because I think that's what's holding that back.
Yeah.
Okay, amazing.
And because I've already mentioned small business, I'll mention our second, which is data and TEFCA, and more investment in TEFCA, and really seeing that policy accelerate. Because the more visibility that we have, the more information that we can get to employees, the better off everybody is.
Okay, amazing. Thank you so much. Join me in thanking our guests on our panel.
Hello. Welcome to our session, The Digital Imperative. I'm really excited to just jump right into it. We heard a little bit in the last session about that better is possible. And I think that's really what we want to talk about today, is how do we use technology to ensure that we're actually getting to better versus just automating. I have a great panel here today. I have Jacob Schiff, who is the Chief AI and Technology Officer from the CMS Innovation Center. I have Carolyn Pearson, who is the Executive Director of the Peterson Health Technology Institute. I have Jen Golsack, who is the CEO of the Digital Medicine Society, or DIME. And we have Mark Harrison on the line. He is the chair of Tower Brook Healthcare Institute. So I want to start with you, Jacob. Karen actually gave you a shout out very early on in this meeting, talking about access. And I think what we really want to hear from you is what do you see tech-enabled care looking like in 5 years, in 10 years? And what do we need to do to get there? How is access sort of stepping us along the way?
Well, it's great to be here. Briefly for context, can everyone hear me clearly? Great. So I work at the Innovation Center, in particular on how can we evolve how we pay for healthcare to enable the fullest potential of technology to meaningfully improve healthcare outcomes and affordability. And I really see us as being at a fork in the road. Fundamentally, technology is a tool. People use tools based on their incentives. And the dominant incentives in our healthcare environment today are to maximize billable activity volume and intensity. And that is where we are seeing most technologies being deployed. A tool like an AI scribe can enable a clinician to shift non-reimbursable activities towards reimbursable activities and maximally capture every billable encounter, every billable event in an encounter. That's the path we're on. It's going to increase healthcare costs. It may or may not have the value to show for it. The reason why I stepped into this role about a year ago is because I'm very optimistic about the better path, which gets to your question. And I've spoken with hundreds of organizations that are seeking to use technology to get us onto that better path. And if we can get the incentives right, we can realize that. So just to illustrate it very briefly, that's a path where we can have truly abundant healthcare available to millions of people to ultimately improve their health. And that means technologies that are enabling the scarce resource that is clinician time to go so much further. That's clinical decision support. It is AI scribing. It is point of care diagnostics. All of these things that support the clinician. It enables every patient to have access to continuous, proactive, high-touch support across lifestyle, medication adherence, navigation, things that we know work but have not been scalable. Technology can enable that. And yes, it's enabling every practice to operate more efficiently. That is possible. That is not the path we're on. If we have time during this session, we'd love to talk about the things that we're doing at CMS to hopefully structure it so that the incentives are there, so that the organizations that are taking these extraordinarily powerful technologies, which are only getting more powerful, towards that end of better healthcare outcomes at a lower cost, will also be the organizations that will grow and do well financially.
Thank you. I want to open that up to the rest of the panel as well. I'm really interested in understanding what is your vision. I want to steal another phrase from somebody earlier today, which was, how do we improve health and how do we improve the health experience? What's your vision for what you want healthcare to look like? And where do you see some of the steps and barriers along the way? And I start with Carolyn.
Great, yeah. Well, we're at the point in the day where maybe some of you are starting to feel depressed because you've figured out that we have like a lot of problems. But none of you are going to want for work. We're all going to still be employed in 10 years. We're not close to fixing it. You know, we have primarily one of the things I focus on is we spend too much money for healthcare in this country and we get too little in return. And as a result, we have millions of people who actually do not have access to affordable care, you know, in a developed nation. And we are sitting at a moment where historically we have had no easy solutions to that. There's no easy button in our jobs. And the technology advancements that we have right now actually, I think, really do change the paradigm of potential for our healthcare system in the country. And we have technology that can deliver clinical outcomes at scale in an affordable manner that could really transform our ability to reduce healthcare costs and improve access while making people healthier. And we've been talking about technology all day. I want to be specific on some examples. So we have digital mental health tools, inclusive of, but not exclusively, AI chatbots that can improve patient symptoms for anxiety and depression at the same level of an in-person talk therapy treatment plan. We have GI management solutions that can be delivered virtually that can improve patient symptoms and reduce spending by thousands of dollars per year for those patients through avoided emergency room visits and hospitalizations. And we have hypertension interventions that can take the huge portion, the 90 million people who have uncontrolled hypertension in this country, and as Cheryl told you, are already seeing a doctor and not getting their blood pressure under control. And we can bring them into blood pressure control in 3 to 4 months compared to what takes 12 months with regular in-office visits. So we have the potential. So why are we not receiving this care every day? And I think there are sort of 3 major barriers that we need to tackle in this conversation. One, we do not have the regulatory clarity and sort of guardrails to enable adoption, particularly of some of the autonomous technology that is really possible today, but not being widely deployed. We don't have the evidence base to make clinicians and in some cases patients and purchasers confident in adopting that kind of technology. And we don't have payment models that incentivize the adoption of care that's actually going to bring costs down and potentially in some cases be able to operate autonomously. We don't have it. And so instead, what we do is accelerate the use of AI for billing, AI for prior auth, and we're layering AI on top of all of the worst parts of our healthcare system, the adversarial, portions of the administrative process that have all of the wrong incentives. And when you put good technology on bad processes, they get faster and they get worse. We're actually like making all of our worst nightmare come more quickly. And so we really have to focus. I think the opportunity is tremendously on the clinical side, and thinking about how we create those regulatory and payment pathways that enable us to embrace the technology that's already here, but we are in no position to really handle with our current approaches. Although I will say, Jacob, I'm really excited is moving the ball forward on that.
I have to agree with your statement that nobody wins the bot war.
Yeah.
Jen, go ahead.
So, I absolutely agree with how powerful the technologies that we already have and what's coming down the pike are going to be. I also think it's an absolute imperative for all of us in the room that if we want to continue to have the healthcare industry exist as we know it, the industry that exists to care for people, then we need to figure out how to make these tools work. And we've got probably a pretty limited window to do that if you speak to most CFOs of most health systems, as well as, just like we were talking about, sort of employers. I think what I'm uncomfortable with is that we continue to talk about this inverse relationship that we think technology can magically deliver between improving outcomes and reducing cost. And I actually think that one of the greatest Achilles heels over the last 10 to 20 years of health policy has been a focus on trying to manifest that inverse relationship. I'm incredibly proud to live in a country where 20 cents in every dollar nearly is spent on healthcare, on caring for people. I think that's wonderful. If we think about the number of people that the healthcare industry employs, this is a critical part of our economy. I think the opportunity here is to say, if we spend this money and if we invest in technologies, imagine the quality of life we can deliver. Imagine quality of life years. Jacob, you and I were talking about this earlier, that we can add to our population. Imagine the productivity of the workforce. Imagine the gains in equity, and yes, I said the word, that we might be able to achieve. I think that's the opportunity, and I think if we try and do both things at the same time, drive down costs and achieve benefits from these incredibly powerful technologies, I think we're on a road to nowhere. We've talked about bending the cost curve for the last 15 years, and we haven't. If anything, it's bending the wrong way still, and outcomes continue to get worse. I think that we have to recognize that these tools need to be deployed in a way where we're actually willing to invest in them, and that we actually believe that the health of the nation is worth investing to the current levels. I think that becomes less terrifying for people. I think it becomes more approachable, and I think it creates opportunities where it's possible to do good and to do well. I think the one other thing I would say is, like the example that I would give, something that just made me want to just bang my head against the wall during the pandemic was, oh, well, now we have telehealth. There's like so much like overutilization. Maybe it's just the care that people needed. Maybe it's just the care that people needed all along. If we are saying that there are challenges to access, if we are saying that there's inequity in care, then how do you plan to drive down costs if you actually want to care for people with these technologies? And so I'd like us to think about how we redress that balance and how we actually address our talk track around this. Otherwise, I think we're on the road to failure.
Yeah, and I think that you make an excellent point when we think about how we have so many areas where access is such a problem. And if technology helps us with that access, it will inherently add costs. It's real costs that aren't being spent now because of the lack of access, but not.
I'm not sure if it will inherently add costs.
Not zero, maybe not in the cost of it now.
I think it can reduce costs. I think bad healthcare is expensive healthcare. So I think if you actually substitute against care that wouldn't have happened, that would have resulted in downstream events, or you substitute for care that would have happened that was lower value, you could drive savings today. And to Carolyn's point earlier, from a sort of first principles perspective, it is now possible to, for pennies on the dollar, deliver abundant care to people that does move those measures that we know improve their health.
I mean, I think that's
So do you think,
Mark, go ahead. We're waiting.
Hey, thank you. And I'm really sorry I can't be with you all in person. I'm having my own little adventure in whole person healthcare right now. I start a new protocol tomorrow for my relapsed myeloma, and I need to be exactly where I am right now. That said, I think that Clay Christensen, who probably many of you either taught you or you know of him, was one of my board members back when I was at Intermountain. And in the last meeting he came to before he died of cancer, he said that if we could do one thing for the health of the population, it would be to provide the ability for every patient to have a navigator and to be able to help them coordinate across multiple specialties, subspecialties, locations, et cetera. And I told him after the meeting, I said, Clay, I think you're right, but I don't think we can afford it. I mean, I think where would we find the people? Where would we find the money? And I think the answer right now is we have that capability with properly constructed agentic companions, navigators, whatever you want to call them. The corollary to this story is another story. It's a physician in a very busy Midwestern city with lots of medical institutions who popped up with unexplained hypertension in his early 60s. Showed up in the ED with blood pressure of 200 over 110, feeling terrible. And in the end, a workup showed that he had Cushing's from a adrenal adenoma. He had such trouble trying to get his subspecialists to work together that he eventually created an AI-powered agent from one of the LLMs that has helped actually bridge those gaps. And I think we're well past the time where we should be cobbling together these sorts of solutions. It should be part and parcel of how we do business, and in no way supplants the role of an excellent internist or family doctor or general surgeon or you name the specialty, but really makes our care safer and in a fulsome way more satisfying for both the provider and the patient.
So one of the things I heard from all of y'all is that incentives matter and that systems will do what they're paid to do. And so I would love to hear just a little bit more from y'all about what do you think is the next best step that we can do to tie payment to meaningful health improvement? Do our current systems allow for that? And we just need to think about how to use them creatively, or do we actually need other approaches completely? And Caroline, I'm going to start with you.
Sure. The other payment systems don't work. As Jacob said, right, we pay for time, we pay for effort, and we have technology largely being purchased through other actors in the system who have natural incentives to work on sort of raising revenue or increasing margins, right? Everyone's performing against their own incentives. And so, if you want to have technology really be able to scale, right, you have to have enough financial incentive to be able to adopt and scale that technology. And you need to do that not by just delivering those finances back to the person who has to purchase it, right? So you need to create a payment model that sort of delinks the technology from the entity that has to purchase it, creates an independent sort of payment incentive for adoption, but does so, I believe, in a more affordable way. And technologies don't need a living wage, and so we need to find ways to insert them. Let our humans provide us the care that only they can provide. And there's a lot that we do in the healthcare system that technology can do very efficiently, and really at decreasing costs over time. And so the existing models don't work. Access is really the first time where we say, okay, let's just pay for outcomes. We have also seen a big shift to performance-based contracting in commercial markets. Mm-hmm. And so thanks for catching up, Medicare. No, the commercial market, the commercial market's been leading, but I think we've seen this whole shift, right? Uniformly, we've said, wait a minute, why are we just paying to adopt interventions? Let's actually make sure that we are paying for outcomes. And so I think that is the beginning, and I hope that we can sort of build on that approach as we continue to get more AI-based technologies available.
Can I build on one thing that
absolutely? You had requested this question, so I
did. Planted it. Thank you. Well, one thing is to build on the point of how the current dominant system is not the right one. I think there's really three ways you can pay for healthcare. You can pay for activities, you can pay for savings, which is what a benchmark effectively is, or you can pay for clinical outcomes. If you pay for activities, which rewards volume, but now this is an activity that is technology delivered that is abundant you're going to explode costs. So I think if we go down that route, we are on the precipice of a lot of hurt. Whereas paying for outcomes, that could be clinical or financial, but giving organizations more flexibility around how they achieve those outcomes, including through the use of technology. Now, all of a sudden, you have a framework that can enable those same capabilities, which today's technology may not be the best one tomorrow. So we're also getting out of the business of picking those winning technologies. Well, now you can get the benefit of those extraordinarily powerful capabilities being deployed towards the outcome you care about, which is likely clinical, as in the case of access, or financial. And then if you pair that with transparency, Mark, to your point about navigation, if you pair that with the ability to make informed choices so that patients, so that referring clinicians are making choices based on who's going to get me better and not bankrupt me, well, now the organizations that are truly delivering better outcomes will be the ones that grow, and the ones that aren't will fall behind, which is the original C in VBC, which was value-based competition. So I think that's how we get there, and I can get into the weeds of access, but I think that's one very practical implementation of how this shows up.
I think that makes a lot of sense, particularly when you're thinking about the clinical outcomes. I think it's a little bit challenging when you're talking about financial outcomes because it's hard to make sure that the people are getting the care that they need on top of that.
Certainly, and also, how do you know what the benchmark? How do you know what it would have cost? You don't have a true counterfactual, so I could talk about that for a while, but I agree.
Mark, I'd love to hear your thoughts on this.
So I suspect most of you know somebody who's either a recent medical school graduate or going to medical school right now. I think the things that we've just heard are 100% true. So I'm in violent agreement with what Caroline and Jacob just discussed. However, our medical students and our residents and our fellows are not learning to do any of this stuff. And most of them were working in really clumsy, clunky academic systems that are almost completely fee for service. How can we expect these folks to come out of their training and be a meaningful change agent for how healthcare is both provided and paid for and oriented? And I think it's time, and maybe it's our friends from CMS can help us with this. Time for a new Flexner report, looking at medical education and what the role of technology is at this inflection point moment in making things better for the people we're meant to serve. And I'll use the word as well, in an equitable fashion.
Yeah, Mark, I was thinking exactly the same. We speak an awful lot about the technologies. We speak an awful lot about the incentives, and both of those things are very important. And then we talk sort of in an incremental fashion about what we want the clinical workforce to do to be able to absorb all of these new incentives, all of these new workflows, all of these powerful technologies. And Mark, it's interesting, you sort of say, look, we really actually need to jump on this. So next week, in fact, the Digital Medicine Society and the AMA, we're hosting a workshop where we really actually want to reimagine what the scope of practice is for physicians in the digital and AI era of medicine. And I will say kudos to John White, who's the CEO of AMA. He's been very open-minded in having a pretty expansive discussion there. But we can't invest this many billions of dollars in technologies that can do things like diagnose, that can make clinical decisions, and not actually imagine what's the role of the physician, the nurse, the behavioral coach that we don't currently count as part of the care team, like all of these different roles in the multidisciplinary care team, if we envisage that AI is actually part of that multidisciplinary care team. And I think that's the third leg of the stool that has been woefully neglected, which is not to say that we don't have to wrap our arms around the technologies, the guardrails around them, Jacob, that we don't think about how we're sort of creating incentives, because one thing healthcare has proven is that it's a system that responds tremendously well to exactly the incentives it's asked to deliver against, right? But if we aren't thinking about the clinical workforce, if we aren't actually thinking about the humans that we are going to layer into those tech stacks, then there's absolutely no way that as long as that conversation is incremental, that we can be transformative with these technologies.
I think that makes a lot of sense. And I want to add on and step back a little bit to talk about the patients. I think that with a lot of the digital health tools, they are patient-facing, and that it allows the patient to be much more involved in their care. I have a couple of stats I wanted to talk about. Kaiser Family Foundation and Gallup both recently released polls on Americans' use of AI for healthcare. And about 30% had used AI recently for health purposes, almost all those general purpose large language models like ChatGPT, like Gemini. And most of them use them actually as to either get quick answers to a health question that they had, or to prepare for a doctor's office, or to debrief from a doctor's office visit. But I did hear two other things, one of which was I couldn't afford to go see the doctor. And the other one was I feel ignored and dismissed by the doctor, which I think are both really critical problems that we need to address. However, having said that, within the other 70% who had not used AI, 80% said they don't use AI because they don't trust it. And so how do we bring the patients along with us on this tech-enabled vision? And I'm going to start with you, Jen, on this one.
I think for a start, we stopped talking about AI. So just to throw some more statistics at you, I think it was NBC who did a survey the other week that said that AI is hated by people only marginally less than most people hate ice at the moment. I mean, and then there was a commencement ceremony on Saturday, and I'm embarrassed that I can't remember the institution, but they started talking about this exciting AI future. It was an engineering school. Everyone just booed. The entire graduating class were like, we don't want to have this conversation. And so what people want is to be cared for. What people want is to be healthy, to be able to engage in all of the activities in their life that are meaningful to them. They want to be able to look after their child, their parent, their spouse. They don't want to be in pain. They don't want to be afraid. They don't want to lose their house because they got cancer. Like, that's the problem to solve for. And so we can talk about AI all day. And I founded and run an organization called the Digital Medicine Society. So you could hazard a guess that I really believe in the transformative power of these technologies. But I don't think it's like, you know, what do we do with AI? I think it's what are the jobs to be done? What are the problems that we need to solve for? What are the pain points that people are facing every day? How do we think about the humans who are already in the system, who are pursuing a vocation? How do we think about the technologies, not that just we have today, but the ones that are coming down the pike, which, to your comments earlier, Jacob, are only going to be orders of magnitude more powerful than what we already have? And that's how we think about it. And, you know, you can say the 70% who haven't used AI don't trust it. But, you know, if you feel dismissed by your physician, you probably don't trust them either. I mean, it's like we could just rearrange the deck chairs all day, or we could actually think about the fact that we have to pair human compassion and expertise with technology to allow patients to have a trusted experience. And one of the things I think is so interesting with the direct-to-patient sort of pathways for drugs is that, you know, how many years have people who have struggled with their weight gone to the physicians, and physicians, not to be unkind, but stressed. We know what it's like to be a primary care provider, and they felt dismissed. And then they had a way through technology to access a medication that could help them without being lectured or shamed. And boy, have people flocked to that. And they've reached into their own pocket as well. That's how much they want a solution. They don't want AI, they want a solution.
I think one of the things we need to think about is how we begin to bring sort of medical AI, right, clinically created AI, and the solutions that everybody is using in the general population together in ways that are really thoughtful. So we don't ask dermatologists to do heart surgery. There's no reason to think that a model that is trained to be a general purpose large language LLM is going to be great at anything else in medicine, right? We have seen much better results when we have purpose-built mental health chatbots. They deliver good clinical care that is the opposite, actually, because it is challenging and redirecting and pushes a patient, unlike some of the sycophantic things you see in other models, right? When we have models that are trained to do clinical diagnosis or to support patient navigation, we get better results. And unfortunately, because of the regulatory environment right now, we've got state laws sort of limiting the ability to adopt some of those purpose-built tools. We have no sort of handoff between the solutions. And so then if you're a consumer who doesn't trust your physician or doesn't have good access, you're left with ChatGPT, because that's what's sitting there in your web browser. And so I think thoughtfully thinking about how we stitch that together, how do we do a handoff so that when you see that ChatGPT is suddenly having a mental health conversation, we move you into a purpose-built model that's really much better suited to handle your needs.
I think if the question is partly how do we think about trust of these solutions by patients, I think, first of all, certainly within CMS and on the government side, we want to really focus on if we can get the right incentives, then the organizations operating within those incentives will almost be able to solve for that trust piece, which is an important step in that process to get to those outcomes. I can tell you that technologies today are actually enabling the technology itself to almost recede into the background a little bit. I'll illustrate by example. I've engaged with hundreds of organizations. There was one I spoke to recently where their solution is a phone number that patients, older adults call, and they talk to it. And intention is to understand that patient's status and be able to support them. And their engagement numbers are extraordinary. 45 minutes plus per day, almost disconcertingly high, very high engagement many months down the line. If you were to talk to some of those older adults and say, do you use technology? Some might say no, but they're talking to an AI. Now, there's a good version of that if we direct that towards better health. But my point being that I think this trust topic, I think will be solved if we get the right incentives. And I actually think technology will not be a poor man's substitute for an alternative. It will be a better one, which actually, Jen, to your point about thinking about the human experience and clinicians, I actually think that technology will also enable us to move from where we stand today, which is clinicians are paid for their time or their hands, which is to say procedures, to move towards getting paid for delivering health and being orchestrators of that with all of these new capabilities that exist.
100%. 100%. And I think trust is always one of these conversations that's so important, but I think trust is a lot more utilitarian than we think, right? I think about the tools that I use outside of healthcare. I don't necessarily confer a lot of trust in the manufacturers or the developers or the institutions like the banks that they serve. But talking about a banking app, if you think I'm going into the branch, you're out of your mind. I don't need to trust them. It's very useful. We need to deliver value. And I think if we can do that, it's going to break through.
I want to let Mark jump in real quick.
Yeah, look, it's a great conversation, completely relevant. I suspect a lot of this, and Jen, it sounds like you would know, varies, but based on demographics, what age you are, what your experiences have been, et cetera. But if we really think this is about trust, people are placing it in the wrong sort of galaxy. We're having between 200,000 and 300,000 Americans die every year from medical errors in our hospitals. They're not safe. We've been at this quality and safety journey for over 20 years now. And I don't know whether any of the rest of you are clinicians. Maybe it's relevant, maybe it's not. But I spent a couple thousand nights in the hospital at the bedside of critically ill kids. And I saw the damage done by well-meaning folks who people really trusted make really dumb mistakes. And I can only imagine that even some of the less sophisticated models than what Caroline, I think very appropriately is advocating for could make a lot of difference if they're paired with good human beings.
I had one addendum to my earlier point. I do think the other thing we can do to support trust is to reinforce the parts of the system, the guardrails that are working so that patients can rest assured. So as one example, HIPAA for data privacy and security. If we bring these technologies into that framework, then a patient can rest assured that their data is being handled appropriately. So that's the other piece that I do think is really important and will broadly support trust in the system.
We are almost out of time, so I want to do just like a rapid round where, and I really want to ask you, and we talked about vision, we talked about some of the incentives, we talked about how to bring patients along with us. If you could change one federal policy in the next 12 months to really push us towards these visions, to push us through towards those incentives, what would that be? I'm going to start with you, Jacob.
Well, I love my job in that I'm able to, as much as possible, work on those things. And within the CMS Innovation Center, it has what I consider to be this superpower, which is the ability to test at scale new ways of paying for care and even to waive law or statute. So I feel like we're relatively unblocked, and there are certain things that I've been privileged to work on directly and certain things that we're working on to come. So I won't answer the question directly, but just say I'm happy to be in this position.
Caroline.
I would say figuring out new payment models and the necessary regulatory wraparound to enable autonomous clinical care to enter our system at scale.
I feel like I've already left the farm a bit today, so I'm just going to keep going. So I think policies that don't erode trust in the institutions that we actually
rely upon to be those sort of guardrails and those intermediaries. And to overshare for a second, I'm a cancer patient, and I've never sat getting an infusion worried about the safety profile or the efficacy of the drug, because I trust FDA. I go home with a pump and I'm trusting that I can fall asleep and it's going to function correctly and it's going to administer drugs in the right dose that have been carefully vetted, that are going to give me every chance to keep living. I don't second guess that. I don't worry about what's in the black box. I trust the institution. And I think about all of the work that you and your colleagues at CMS do, Jacob, and I think about all of the brilliant work that FDA is doing. If anyone knew anywhere in the world how to regulate AI, it would have been done by now. Then no one's sitting in an ivory tower with the secret plan just waiting, until they confer it on us. We've all got to be in this together. That's what you do. That's what we do at the Digital Medicine Society. And I think the policies have to support those institutions that need to serve as our trusted intermediaries. And that to me is the most important thing right now, because if we lose that trust, if we have instances of harm, boy, we're never going to capture the value of these technologies.
And Mark, I'll let you have the last word.
Thanks. So from the sublime to the mundane, Jacob, can we please get rid of the state licensing, state-based licensing for nursing and physicians? So, I mean, in an era of workforce shortages, it just seems absolutely ridiculous that you can be sitting across the river from another state and you can't have a telehealth visit from somebody in your own community. And I know you can't do that like with a wave of your hand, Jacob. But if we look at the workforce shortages amongst doctors alone, it's just completely ridiculous to think that we're wasting any capacity whatsoever to serving our neighbors. And I think this is a sensible one that may actually garner real bipartisan support if we're careful.
Well, I think that was an excellent last word. Thank you so much for joining us. I think this was a wonderful panel. And I think we're ready for our last session.
Afternoon, and we have one more session to go. We're running a little bit late, not only because we had so many great comments and perspectives on the biggest challenges facing healthcare in the next decade, but it's also a little bit convenient because our closing speaker was a little bit, probably coming from the White House or somewhere, right, Chris? Great to see you. All right, have a seat. So please stay for this session. We may run a couple of minutes late, but I promise the bar next door will still be open. For those of you who are with us online, I think this is going to be worthwhile. Chris, I'm going to skip the introduction aside from saying you're the Director of Medicare, Deputy Administrator of CMS, Senior Advisor to HHS Secretary Robert F. Kennedy Jr. Thank you on top of everything else you've been dealing with today, this week, and in this unique combination of jobs for coming here to close out our discussion on healthcare for the next 10 years. Where do we want to end up and how do we get there? As you probably just heard on the way in, there is a whole lot of optimism and hope about digital health, AI, combining with other changes, things that you've seen in your own and contributed to in your own career.
Well, I'm optimistic. I'm optimistic that Jacob's going to solve state-based credentialing.
Yeah, I saw that. I added to
next
his
week,
list.
So
that's great.
I have a follow-up on that. That was outstanding.
Yes, there are, and hopefully get there. But I have to say, having been in government myself, the jobs that you're in, making these changes and state-based licensing, along a list of 100 other policy issues that are not really designed for where healthcare is today or where it could be in 10 years. This is really hard, on top of dealing with changes at the FDA and other federal agencies, the HHS reform agenda. I expect you feel this too from day to day, but what keeps you going through all the challenges needed to make the kinds of reforms that you, others in this room, are committed to in the next decade? But it sure doesn't seem easy. What gets you up every morning?
I just came from the White House, and I was with a particularly senior person who said, "Is this your best week ever?" And absolutely, absolutely. Look, I think, as you said, so I've been fortunate to run the Center for Medicare under Dr. Oz for the last year. And then about 2.5 months ago, was tasked to take a different role as chief counselor, overseeing all of Health and Human Services on a day-to-day basis. From an operational perspective, it would be disingenuous if I said that I wasn't going pretty all out right now.
Yeah.
And if anybody's been watching, there are a lot of changes at the department, and there have been a lot of changes over the last couple of months, and for good reasons. I'm not sure anybody expected that healthcare was going to figure quite so prominently in this administration as it has. But obviously there was a lot of activity last year. There's been a lot of focus this year. There's a lot of focus on affordability and accessibility of healthcare appropriately for every American. And as a result of that, there's a lot of focus on the Department of Health and Human Services and making sure that we are doing our best work, that we've got the right people in the right roles with the right processes and the right systems, all tasked against the right set of priorities, and that we're not getting distracted. We're not focusing on other things. And so you've seen, and probably will continue to some extent, continue to see a series of changes that I think are positively met, that as we focus more, we get more precise in our execution. The metric that I am most focused on tracking is trust, which was discussed previously. Yeah. And I think about that across all of our institutions. I was so grateful that the panelists referenced that she doesn't have to worry about trust when a device comes out of the FDA. She just knows she could fall asleep, it's going to do its job, and it's going to give her her best chance. I loved that framing. I want that to be true of every institution. It's how I grew up, looking at these extraordinary organizations. I looked at the CDC when I was a kid. I had family members that worked there, but they were the ninja assassin squad that was the first online whenever there was a challenge anywhere in the world. And you knew that they had it. They had it covered. You didn't have to worry at night. I could sleep soundly. It wasn't an issue, right? We knew the FDA was going to be on the bleeding edge of approving and making sure that things were safe and effective by the time they made its way into our home, right? And NIH was going to do the best science. The smartest people, the smartest scientists on the planet were going to be there. And they were going to do the research that no one else was doing. And the government was going to fund that research, where maybe private markets weren't stepping up. And CMS is going to be there, going to figure out how to pay for it all, and all these other agencies. That only works if you have trust. High-performing teams operate on the basis of trust. And if you don't have it, you don't have high performance. You can't stay focused. You can't execute. And so we're focused on those things. I'm focused on that metric at every level of our career team and making sure that they feel respected, that they know that we trust them so that they can do their best work because they've dedicated their lives in service of their country, in service of these extraordinary programs, that the American people can trust these programs as well. And so that's extraordinarily motivating. My personal motivation is, in fact, very personal, which is anyone who's a parent understands that the social contract when you decide to have a child implicitly, but should be manifest explicitly, is that we're going to leave our domain, our little space, better than we found it for them, right? That's the deal as parents. And I've worked in healthcare for a long time, and I've benefited from it. My family has benefited from it, and I've been so grateful to be a part of this industry. But if I'm really, really candid with myself, I don't think that it's in a better place than when I started. We're less healthy as a country. We know that. You know the statistics. You know the chronic disease rate, 6 in 10 Americans, the obesity rates, right? 43%, the overweight rates. You understand what's going on in CKUM. You understand the cost rates, double GDP, 19% of total GDP. You know, these are problems. That's not better. It's worse. It's going the wrong direction. And so I find that to be highly motivating because I have 4 young children. And right now they think the sky's the limit. They believe that it is. They have full, unfettered, unlimited potential in their minds. And they have parents who are encouraging them that they can do anything they want, that they can invent anything they want. They can change the world in any way, shape, or form that they want. And as far as I can tell, the only thing that's going to stand between them and those unfettered dreams is if they don't have health, they don't have health care. And so that's why CMS's mission under Administrator Oz is to unlock the full potential of every American by helping them live their healthiest lives. People have heard me say this before. You can't do that if you're not healthy. And so our mission as a department, that our moral obligation as a country should be and is to do exactly that, to make sure that we are helping Americans be the healthiest possible and that we are alleviating human suffering at every level. And so how could I not be incredibly motivated, even if I'm burning the candle at both ends right now, to get to sit in this seat, to be able to have the audacity to imagine a problem or look at a problem and think, oh my gosh, we could actually solve that for the whole country. We could do that quickly. We could do that in a matter of months or years. What a privilege.
Yeah.
So how could you possibly squander a minute of that time when somebody gives you that extraordinary opportunity of something that has nothing to do with red, blue, left, right lines and has to do with the most core and central thing that everyone cares about, which is life with joy and health. So that's the motivation.
This is very clear from the discussions today and from work that you've done, others have done, that this is a critical time for that, where there are new opportunities on the one hand, but real challenges in getting some of the most promising directions to take flight on the others. You've only been in the HHS job for a limited period of time, but you have a history in the private sector, including in applying technology to addressing healthcare and health problems, and over the past year plus, leading CM, as you described. You've got quite a reputation as being a team builder. You mentioned it first, between the political leadership in the agency, which comes and goes, and the career staff, which is there and critical to executing on policies, but building a team, building teams in that direction, building teams across, I think maybe this administration more than others, a diverse set of viewpoints that needs to come together to act, to make policy decisions and execute across party lines, across stakeholder perspectives. You do so much outreach, building teams with the private sector. I've been part of that on the receiving end of your engagement outside. What are your experiences so far about the most effective ways to do that when you're trying to make major lasting change in public policy that is just not going to happen overnight? It's going to take some work to get from here to there. It's going to take teams and probably take some legacy after you've moved on.
No question. We keep quoting the $4.9 trillion of U.S. healthcare. Latest number, by the way, is 5.3. Goody, we're going in the right direction. Oh, wait, we're not. And you're right. You don't turn that barge overnight. And most of what we're trying to do won't happen within the term. The goal is to set a flywheel in motion that can't be stopped or with great difficulty, so that you've done the hard part of orchestrating the plan and putting the resources behind it. And then the hardest part, perhaps of all, which is ensuring that those who continue are bought into that vision and come hell or high water, will not stop.
And not just going to react and move in the opposite direction or something.
And so how do you do that?
Yeah.
You get people bought in the first place. How do you get people bought in? Well, hopefully you've got a worthy idea. Better, it wasn't your idea, it was their idea. And they take ownership of it. And then you empowered them and you equipped them the resources and the respect necessary to execute that idea. And then they don't want to let it go. They can't let it go. It becomes all consuming. It becomes the thing that must be solved. And then you don't have to be involved with it at all, because it will continue with great momentum, hopefully accelerating along the way. And so if you think about, I'll pick on the Center for Medicare, for example, extraordinary career team, stunningly capable individuals. I showed up days 2 and 3. I did about 50 interviews with directs and skip levels. Wanted to get to know the team. Wanted to understand who they were personally, what was important to them. Tell me about your families. Tell me about what's important here. Why did you come here? Why are you here? Let me tell you about me and why I'm here. Why my personal journey? Why did I show up in this role? And then almost every single one of those questions, they would say, well, what are your priorities? We want to know your priorities, because that's the custom. Someone like me shows up and says, okay, this is what we're going to do. And I had done that, by the way. I'd probably had 500 conversations before I got in April of last year with different folks. And what should we be focused on? What are the priorities? You and I had a bunch of conversations, and you had a lot of good ideas. And I had lists and lists and lists of pages of ideas. And I had put together this 40-slide PowerPoint of all the things across categories that I wanted to focus on. And it occurred to me as I was talking to all these extraordinary leaders that the ego one would have to think that I had somehow conceived of or heard of an idea that they had already not carefully considered, and probably at much greater depth than me, was rather ridiculous. So I pulled together the top 50 CM leaders, and we did a sticky note exercise, and I asked them ahead of time to bring their best ideas of things that they really wanted to focus on. And at one point, we got to one of my leaders, and she's this lovely individual who runs one of the groups. And she's been at CMS for, I don't know, 25 or 30 years. She's clearly well regarded. I'm pretty confident she didn't vote for this administration, and it's her turn. She's a little crusty, and she's one of my very favorite people. And she's got a stack of sticky notes. They're all related to rev cycle components. And I'm like, hey, what have you got? I'd want to hear your ideas. And she says, well, I've got 6 ideas, related to coding, but I know we aren't going to do them. So let's move on to the next person. And she said, no administration has wanted to do these over the last, several. And I said, well, now I want to hear them. And she's rattling through these a little reluctantly. I said, great, throw them on the board. She kind of looks with surprise. They were all good ideas. By the way, they were all on my list. They were her ideas. And it empowered the team, it empowered her. And all of a sudden she had ownership and it just lit up. She was engaged. She felt respected. That will continue. Yeah. That doesn't need me, right? I'm so not additive in that equation. And that's true, I think, usually, right? One of the greatest pieces of I got as of advice when I was early, just about to become a CEO for the first time. Our company was very, very small, fewer than 10 people. And it was from a mentor who had been a CEO of many, many large, well-known organizations. And he said, 2 things you need to figure out. 1, you need to figure out how to get extraordinary performance from ordinary people. And 2, when you show up at work and you realize you don't have anything to do because you have somebody else on your team taking care of everything, that's when you figured it out. That's how you figured out how to be a great leader. I resent him a little bit because I'm not sure I ever figured out how to do that as a CEO, but it's been a true north of what I work toward, which is empowering your team, empowering your people.
It is a great goal.
And that's what we do. And so that's what's happening now.
And so as we think about the big picture here around the potential for more affordable, accessible healthcare, which I think not an easy path to get there, but it includes leveraging technology, AI, the right data available for each person. So we've gotten into things like TEFCA and HIPAA and data exchange and those sorts of things. It includes definitely humans in the loop as far as people can see out, not to do necessarily anything like the same thing that we're paying for with activity payments for clinicians today, but teams and care that's around people and trusted. There are a lot of tracks underway to help get there, empowering people, turning sort of ChatGPT, Gemini, things like that we talked about today into tools that are really giving people the right evidence, the right information from a whole person standpoint. Helping healthcare systems, which have the people like Mark Harrison's been part of them, led innovative ones out in Utah, helping them be more focused on whole person care. And also the kind of innovators, the new kinds of providers in Medicare that Jacob and the Access program are creating, but maybe working more closely with the ACOs and the primary care groups and the specialty care groups that are trying to keep a human in the loop, but as a team that builds out the right supports for trust and engaging people and helping them through the most difficult, challenging situations in their lives. And along with that, staying healthy too. There are policies underway that are helping each of those move forward. If you are extending your team building strategy to the people here in this room who all would like to get to that better future, what kind of things would you encourage us to think about for the sticky notes or the lead steps to focus on to move these forward? Is it accountable care steps that you're undertaking in Medicare Advantage modernization? Is it steps to make the shared savings program with LEAD more aligned for the future? What are the things that you'd like to leave this group with?
I think first and foremost would be to take big, bold bets and hard swings. I think one of the criticisms I might have of some of our prior efforts as an industry, government and non-government, is that healthcare is an iterative game. And we've all accepted that, right? We make small changes. And there are good reasons for that. The Silicon Valley mantra of move fast and break things we shouldn't be breaking humans. That's not a good outcome. And so it doesn't apply. But it's possible that we swung the pendulum a little bit too far in the process. And I would argue that the compounded incremental changes, even drawn out another 100 years, will come 70 years too late for the sustainability of healthcare, both from an economic and a clinical perspective. And so we need to find ways to take bigger, bolder bets. I need to encourage, and I'm trying to encourage my team, I think certainly Dr. Oz is, Secretary Kennedy is, to take bigger swings in places where if we miss, there isn't human harm. And there are plenty of those opportunities. But we're not actually the ones that take the swings. You are. Our job is not to solve the problems. It is to create the environment and a level playing field in which the market can solve the problems. And we should step in on specific problems only when there's a market failure. Why? You can move faster. You can be more creative with greater ingenuity. You're closer to the problems, the patients, the situations, their lived experiences. We can create that level playing field between incumbents and insurgents, as we like to talk about, so that insurgents have an equal and fair shake at challenging incumbent, which then causes the incumbent either to go out of business or to become an insurgent themselves. And so what we want from you first as an ask is to name those things for us, to name those asymmetric disadvantages in the market that block insurgency, that block entrepreneurialism, so that we can create an environment where those folks with a great idea who are scrappy, but even resource constrained, can come in and tackle this $5.3 trillion behemoth that affects 340 million people in our country and actually have a chance at winning. And there are things that we can do to help with that, but we need your best ideas. And you see things that we don't see. You see them faster and sooner than we see them if we do. So that'd be part one. Part two then is us making sure that we do create an environment that manages to maintain safety and efficacy from a device perspective. I'm using the actual definition of that, from the FDA perspective of AI in particular, but also for us to be cognizant that we're at risk of seeing a repeat of technology innovation in healthcare that has been nothing but stifled repeatedly over decades. And it would be foolish, it would be naive to somehow, I would argue, falsely conclude that AI will somehow be different. AI is clearly impacting everything all at once across the broad economy, but we are really quite gifted in healthcare. It's stifling innovation and not getting the best of it. Insert Exhibit A, the fax machine. Insert Exhibit B, we have EMRs, but we can't actually interoperate and share records. Let's just rattle down all of the different things. I can't schedule online with certain providers. I've got to pick up the phone, all these different use cases where it's easy and seamless everywhere else, but I can't get that done in healthcare. And so to assume naively, like with value-based care, that if we just set the incentives, the market will figure it out, well, that didn't work out so well. Because it turns out if you go to med school, we teach you how to care for patients, but maybe we don't teach you how to adopt technology or how to use it in novel ways or how to think about cost-adjusted outcomes, or we don't teach you about value-based care. And then we're somehow surprised when we said, well, yeah, but we were going to pay you more if you just kept them healthier. You got to keep more and you didn't figure it out. It's like, well, maybe we didn't give you the time and the resources and the tools to actually go do that. And so we need to find ways to equip the market. We need your best ideas to do that as well. But we should not repeat the sins of the past, or we will not get the results of the future that we so desperately desire and need. Because we do actually have this generationally unique technology at a clear inflection point of demand and need that, if appropriately adjudicated and deployed, could actually inflect the cost curve and the access point and the quality bend all at the same time. That's the trifecta. That's the holy grail. That's extraordinary. So we're doing a bunch of things quietly ourselves. CMS has a bunch, as we think about, and Jacob's talked about that. He is the brilliant author of the access model, which itself is just scratching the surface, even though it's extraordinary. But how do we think about coverage? How do we think about market access? How do we think about reimbursement appropriately that's both deflationary and tied to outcomes as opposed to inputs? Even though everything else that we reimburse for is basically, with the exception of maybe 12 to 14% of care in the United States, is still fee-for-service as a function of RVUs and time-based codes, right? Times a conversion factor. How do we think about that regulatory framework? It was talked about earlier. If it was easy to figure out a regulatory framework for AI, it would have already been done. Well, guess what? We actually do need to figure out how to do it, though. And you have an FDA that's full of extraordinary scientists, but we had this notion where we have episodic approvals. Give me your molecule, I will evaluate it, I will approve it, and then off you go into the marketplace. And now you have this technology that is changing literally by day or by week. How do I create that serial approval model or that validation model so I can still maintain my statutory and moral obligations of safety and efficacy while actually allowing this result to occur?
Yeah.
Similarly, how do I address interoperability? It's 2026. We still fax records. My wife just had this happen again. She got imaging done once. They faxed it over to her doctor's office. Guess what? They faxed it to the wrong location. Nobody knew. Her appointment gets canceled the day before because they don't have the records. They didn't get the read, so there was no reason to have an appointment on a time-sensitive issue. And it's 2026, and somehow we accept that. That's all this healthcare happens. We'll just reschedule. By the way, it takes 6 to 8 weeks to reschedule. So we have to fix that. We have to fix these things. Data belongs to the patient. It needs to go wherever the patient wants it to go. It has to feed the AI. The AI has to be safe and efficacious. We got to be able to fall asleep and not worry that it's going to act in poor ways. But it also has to be able to innovate and respect IP so that the innovators will continue to innovate. Because I'm reminded of this every time. I've said this example before. I've got pasty white skin, a history of skin cancer. So I'm on the 12-month plan with my dermatologist. It takes 9 months to get an appointment. Heaven forbid if I have to reschedule for an unforeseen trip. Like I'm months and months further out. My visits last on average 7 minutes. And my bill on average, I've paid attention to this, is generally well over $1,000 per visit, right, of what gets submitted. And yet we still have people dying of skin cancer, which is like the most preventable cancer. And the only reason you generally will die of skin cancer is because you didn't get it caught early. That tells me we have a giant line out the door of demand for dermatology appointments and skin checks that's unmet. That sure sounds like a use case for AI and novel computer vision, not to replace dermatologists, but to be a physician extender, to augment them, to do that basic skin check, perhaps at home, and then to nudge for these people like me who need to go in because they actually need a procedure, need to have something corrected. And then maybe we could stop people from dying from skin cancer, and then we repeat that 4,000 times more. And lo and behold, we step back and realize $2 of compute an hour actually extended our physicians and our nurses. By the way, you need state credentialing to fix that. So Jacob, like next
back
week,
to Jacob, yeah.
For real, like we actually need that. But that's the vision. That's the opportunity. Yeah. We have to do that with you. We can't do that, but we can create the conditions for that utopic vision. And by the way, it's not utopic. It's not impossible. And I get that I'm an idealist. I'm an entrepreneur. Like I literally can't process the word no. Somebody says no, it is like I'm seeing red and I'm just going to charge through. It does not compute for me as a word. But even despite that, like I'm such an optimist about healthcare because I get the privilege of interacting with people like you and all of you on a day-to-day basis from this perch. And I can't help but go home at night and just feel unbelievably encouraged despite the tales of human suffering, despite talking to our beneficiaries, which I do every week, and hearing truly heartbreaking tales of challenge and despair. I look and I see good people who are drawn into this industry and want to do good things. And every now and then, sometimes they forget and they have to be reminded why they got there. But that's usually not so hard to do. And then I see them make extraordinary decisions.
Yeah.
And that gives me hope in humanity. That gives me hope for our industry. This is a solvable problem.
You started out with 2 basic points that I'm taking away. The flywheel concept, and you went through some of the key elements of that: data, focus on people, payment, et cetera. But the other one I think is even more important. I guess you're definitely an optimist. I feel that too.
I am.
But you're a realistic one in terms of getting there. You know this is not easy. Any final thoughts before we break? I really appreciate the tone that you're leaving us with. This is not going to be easy, but it is a solvable set of problems, especially building that flywheel and keeping that vision, that optimism together.
I am an optimist. I would say I'm a pragmatic optimist. Ideas are cheap and easy. I always kind of laugh when a company's in stealth as though the idea is the hard part. It's not. I can give you 20, multi-billion-dollar ideas right now and you're free to take them. What sets everybody apart, right? The winners and the losers are people who actually execute, who spend the time to do the hard, unglorious work in the dark of the night, right? Who make the sacrifice, who figure out how to empower others who set a vision of people who will unrelentingly run through brick walls in pursuit of that shared vision, not one person's vision, but they take ownership and it becomes shared. And in that process, that collective group accomplishes something that today was deemed intractable and impossible. But it's all about execution. It is people, it is processes, and it is systems. And it is doing the hard, unglorious work. But people know how to do that. You know how to do that. We're doing that at HHS right now. I hope you see the fruits of that. We will continue to execute. We will execute against the Secretary's vision, the President's vision. We will execute in service of the American people, which is who we serve, no one else. We serve taxpayers, we serve beneficiaries. We will execute against the mission of unlocking full potential of every American by helping them be their healthiest lives. We need your help to do it, but that is solvable. And it is a moral mandate. And we do have children and we do have grandchildren, and we must leave it better than we found it. And we can do it now. We're at an inflection point. This is doable. But we have to come together. We have to trust. There has to be sacrifice. There has to be shared sacrifice. One person's friction is another person's margin, but perhaps that profit pool shouldn't exist anymore. We need to create maybe a new profit pool and blow up the old profit pools because their cost outweighs their value. We're not judge, jury, and executioner, but we are arbiters. And I will tell you that while we make mistakes and we will ask for grace from you, we have no ulterior motives. It is the most liberating position in the world to sit in our seats right now, where I sit. Never in my professional career have I been able to be in a role where I had nothing personally to gain. I've divested of my investments. There's no kind of extra compensatory mechanism. I'm not looking for the job on the other side. I have nothing to gain. I get lots of inputs, and then we do our very best to make the best decisions possible, understanding many competing viewpoints. And we might get it wrong from time to time, but it certainly won't be because of a lack of effort or lack of intentionality or a lack of a pure intention and motive. And what an extraordinary and privileged position to get to be. We're so appreciative of all of you. I'm so grateful to get to be here with you today.
Chris, thank you for being here. Thanks, and thanks for what you've done. We are wrapping up. I hope Chris can stay long enough to join you all for a drink, but he definitely needs a break. I want to say thanks to all of you. The kinds of issues that we talked about today is exactly why the Duke-Margolis Institute is here. It's why we are so privileged to be able to work with all of you in the room, all of those of you who are joining us online. And while this is hard work, we want to keep building that flywheel together. I do want to give a special thanks to our sponsors who made this conference possible. Also, thanks to Bristol-Myers Squibb for the reception we're about to enjoy. Like I said at the beginning, our goal here wasn't to solve all the issues we brought up today, but it was to bring people together, to look forward, to remember that these issues may be hard, may be bigger than what any of us can do alone, but it is not something that's bigger than what we can all do together. So thank you all for making today possible. Thanks for making the Duke-Margolis Institute possible, and thanks in advance for your commitment, your interest, and your contributions to working together to transforming healthcare in the years ahead. And have a good evening.